Care Board for the North East and North Cumbria, held today on the 31st of January 2023. I'll start by giving apologies for absence. We have apologies from Nicola Bailey, who is our Area Director for the North East and North Cumbria, or northern part of the North East and North Cumbria, and she's represented today by Joe Corrigan, who's the Place Director for Newcastle. Kath McAvoy-Carr has had to withdraw at short notice because of family illness. Councillor Shane Moore has sent his apologies, and Hannah Bowes, our Non-Executive Director, will be arriving a little late. Other than that, I think everybody's present. Can I just ask, in addition to declarations of interest that you have already made and that are in the public domain, have you any declarations of interest that pertain to this particular meeting that you wanted to declare? Thank you. Eileen.
Hi, Liam. There's an item on page 9 which is to do with the Learning Improvement Network and the award from the Health Foundation of £250,000 to evaluate the impact. Some of the members of the NIHR Applied Research Collaboration have supported colleagues in the ICB to secure that funding, and I'm the Director of the Applied Research Collaboration. I've flagged this already and I'll be amending my conflict of interest.
Thank you. Then we bear it in mind when we get to that point in the agenda. Moving on then to the minutes of the meeting held on the 29th of November 2022. Are there any points of accuracy anybody wants to make on that? Jacqueline.
Thank you, Chair. Yes, on page 7 under the elective care, paragraph 1, just a couple of numbers missing. Unfortunately, the total waiting list size is somewhat larger.
Need to go a little bit closer to the mic.
So the total waiting list size is written as 3444, when in fact it's 344,489 at that point, so the 89's missing off the number. So just need to correct him, thanks.
Okay, so we'll make that correction to the minutes of the previous meeting. Thank you. Any other points? Thank you. Are there any matters arising that are not otherwise covered on the agenda? No, thank you very much indeed. Are there any items of other business that you wanted to add to the agenda so that we have an idea of those before we start into the substantive items? No, thank you very much. So then there's a section of the agenda, item 7, which deals with a number of areas of strategy and performance, and we have changed the format of the agenda for this meeting to include several items that will give us the chance for a deeper and longer discussion relating to digital and data, relating to discharge from hospitals, and relating to maternity services. And on that last item, we have joining us Dr. Bill Kirkup, who has done a number of reviews of maternity service failures in different parts of the country, notably Morecambe Bay, but most recently in East Kent. And he's agreed to come along today and talk about some of the findings of his most recent inquiry in East Kent and some of the general lessons that have been learned. So we have scheduled those items to allow a longer discussion, but I will keep control of the time so that if we're running over, we will have to stop the items at an appropriate moment in the discussion, just to give us the chance to cover everything on the agenda. So that's section 7, and in that section we start off with the Chief Executive's report.
Thank you, Chair. Good morning, everybody. I will take my report as read. It covers a number of items. What I would like to do is just to briefly touch on the launched yesterday the government's plan to recover urgent and emergency care services. And you may be aware that we had a visit from the Prime Minister yesterday down in Tees Valley, at Darlington, and the Secretary of State for Health and the NHS Chief Executive, Amanda Pritchard. They arrived very early in the morning and undertook a visit at North Tees Hospitals Trust, which has been cited nationally as good practice, particularly in terms of their admission avoidance, out-of-hospital care, and their work to deliver virtual wards. What I would just say is I think that is work that's been developed over several years, and really, I think, has been really at the heart of that is the relationships with the local authority, the multiple pathways that are clear to all of the clinicians and practitioners in the area to wherever possible support people to receive care and support at home, but also to get people home quickly. They have one of the lowest percentage for non-criteria to reside in hospital, and I think certainly the work there, it's attracted significant national interest, hence the visit from the Prime Minister. I think the challenge is how do you replicate that in other areas, and we've got a comprehensive item on discharge today that our Chief Nurse David Purdy will be presenting along with Anne Workman, who's been really pivotal in that work on Tees Valley. And I think whilst you can develop pathways, new systems, new protocols, have digital and data applications in there to support that, I think it's really the relationships and it's the trust that's built up over many years. But I do want to commend our colleagues in the Tees Valley for that work and the national interest. The Prime Minister then went on to attend Teesside University, a fantastic facility and campus in the Darlington area. It's their main campus for apprenticeships, and took the opportunity with the national press in attendance to present the government's plan to recover urgent and emergency care services. What I would say for us here in the North East North Cumbria is that we will now be taking that plan and looking at that in the context of our own urgent and emergency recovery plan, which for us the priorities have been focusing on three areas: earlier triage to wherever we can support people to be signposted in to the right support at the right time. We'll also have our continued focus around discharge and primary care access. The national plan announced additional ambulances, 800 nationally, 100 of those being mental health ambulances. That is something we're exploring here in the North East and North Cumbria. Whilst the capital funding is provided nationally, we will have to find the revenue for the staffing support within existing resources. So we have ongoing conversations with our providers in relation to that. The plan also made a commitment to make the increased capacity in hospital beds that we've seen, some of that increased capacity over the winter period, substantive for the longer term. I think, again, whilst we know that the capacity in our hospitals is critically important, it's also the capacity in our care homes in the community. It's also how we use our hospices and also all of our community services. So whilst I think we really do welcome the government's commitment around the additional hospital-based capacity, again, for us as a system, we also need to make sure our focus does remain in the community services and those alternatives. So that's a new plan. As part of that, we will get a percentage of the funding available. However, like many announcements, some of the funding has already been committed. It's within our plans already, and we're focused on delivering those. And then secondly, I just wanted to highlight again, we've received an additional 27 million as part of the 200 million pounds of discharge funding across our system. And again, just want to commend our teams across our NHS organisations and our local authorities who continue to work very closely together to maximise the use of the available resource to the benefit of our system, and particularly patients, their families, and indeed our staff. And then finally, Chair, if I just may, the winter period, if we could sort of take that being sort of Christmas, New Year, was an incredibly demanding period on our system. We saw the peaks of flu admissions increase, COVID, and the impact of that also on our workforce. And I think that also combined with industrial action has meant that our workforce, our organisations, our partners have been working absolutely tirelessly over this period to maintain safe delivery of services. And I just want to take this opportunity, Chair, to commend the workforce right across from our community and voluntary sector organisations, our GPs, our primary care teams, our community pharmacies, our social care teams, our hospital teams, our mental health teams. Everyone working in the system has been impacted during this period, and I think that we've really been able to demonstrate resilience. I think we've also learnt some things, so we've undertaken rapid after-action reviews following the industrial strikes, particularly following the last week in December and the first week in January, and we're continuing to put our learning into good use. And again, part of that has been how we're utilising our system control centre. And later on today, the board will be having a development session looking at how we're using that. And our medical director, Neil, recently attended a meeting with the chief officer responsible for emergency planning across England, who's particularly looking at the way in which we've set up our strategic coordination centre and how we're using that data. So I think there's a lot of hope to be taken from the way in which our services responded. However, I don't want to underplay the impact of the pressures that they have experienced and the importance of us needing to continue our focus around how we integrate our community services. And I think that's why our strategy and the ambition in our strategy that's on our agenda today is absolutely so critical to ensure that's sustainable into the future. And Chair, my report today also appends our emergency planning and resilience paper for assurance, which is a technical requirement to the board to support. And our emergency accountable officer is Jacqueline Myers, and the paper is here today for approval, and there may be a couple of points Jacqueline wishes to add now, but that's the only decision to be taken with my paper today, Chair.
Jacqueline, yes, please.
Yeah, very briefly, Chair. When the ICB was established, we also became a Category 1 organisation under the Civil Contingencies Act, and we have responsibility, sort of twin responsibility, both to assure ourselves that we're prepared as an organisation from a sort of emergency preparedness, resilience and response point of view, and there are a set of standards we have to assess ourselves against, but we also take the lead role in assessing the preparedness of our Category 1 organisations, the 11 foundation trusts within our patch. So you have a detailed paper in the pack. We've also just yesterday appended all of the detail behind that, so you can see that. The headline is we assessed ourselves as partially compliant. That's better than it sounds because we're 81% compliant, fully compliant with 38 standards and partially compliant with 9. And just to give a little bit of further reassurance, we went through a peer review process with the regional team of NHS England and involving the other 3 ICBs in our region. The other 3 have also assessed themselves as partially compliant. I think it reflects where we are. I feel confident that with the work programme we're setting out, we'll see a better performance when we assess ourselves in 9 months' time. And we're very clear where the areas are that we need to do further work, which are around, mainly around business continuity, a little bit more work around testing our plans. So sort of commend the paper for endorsement. Unfortunately, the timelines this year didn't allow us to bring it here before it was submitted. So it has been submitted subject to board approval. I'm happy to take any questions. Thanks, Chair.
Okay, questions and comments on this then? Yes, please, David.
Thank you. A 3-pronged question, if I may, about the joint forward plan. Does the timescale, a tight timescale outlined on page 26, enable local authority place-based plans to be meaningfully included? And also, does the engagement with the broad range of partners include representation from the wider determinants and the wider public? And thirdly, will there be a recurrent theme of tackling inequalities throughout this plan? Thank you.
Jacqueline, you take
Sure.
that, so
I
ask
think-
Sam if she wants to add anything.
Yeah, I think, David, your question pertains to the strategy paper rather than the emergency planning paper, but I can take it now, Chair, if that's helpful.
It might be better to keep it until we reach the stress. Is that okay with you, David?
Fine,
Yeah.
absolutely fine.
Okay, thank you very much indeed. Other comments and questions then on the Chief Executive's report and the paper attached that Jacqueline's referred to? No? Are you happy to approve that then? Thank you very much. Okay, move on then to the next item, 7.2, and this is your item, Jacqueline, the Integrated Delivery Report.
Thank you, Chair. So the paper you have before you is the report that mainly covers performance up to the end of November. I'm going to make a few remarks to bring us slightly up to date in some areas, but just a couple of things I need to draw the board's attention to, Chair. Firstly, regrettably, there's an error in the paper. It's on page 112 of the board pack, and it's where we refer to serious incidents, and in particular the never events that have occurred year to date, where it says that there have been 15 year to date, of which 6 are in SFT, meaning South Tyneside and Sunderland FT. That should be STHFT, South Tees Hospital Foundation Trust. So deep apologies that we made a mistake there, and particularly to our partner colleague Ken, who probably took a deep breath when he read that error in the report. I have got the detail behind that if people need to see that, but apologies for that mistake there. Second thing I just wanted to draw the board's attention to is that I've been doing some work with John as the chair of the Finance, Performance and Investment Committee, just to make sure that we have the right order of play in terms of reports being discussed and considered at detail in the board committee prior coming to full board. So the report you have before you, the performance elements, didn't go to the January meeting of the Finance and Performance Committee. However, we didn't want to bring an older report this time, so I agreed as an exception with John that we'd bring this report. We've now mapped out all of the reporting timelines to do with when data becomes available to us, and we're confident we can make sure that that order of play is corrected in future meetings, Chair. As ever, this is a really detailed report, covers a wide range of metrics, all of which we're working on in different parts of the Integrated Care Board, indeed the wider system. At the start of the report, we highlight some key changes, and I'm just going to make a couple of comments about that, and then I'll open up to any questions on the detail of the report. Firstly, in relation to ambulance handover delays, you can see at the point that we published the data that's considered in this report, we had a really concerning trend in relation to handover delays, and that is in line with the situation nationally also, and Sam referred to the very difficult period that we had in the run-up to Christmas and New Year. As you know, the target here is 18 minutes, and we saw ourselves go close to an hour, and indeed I think you've probably seen in the national press reported that for the month of December we're looking at 90 minutes as a national average. So it's early days, but I'm pleased to report that we are seeing some improvements in this metric, enough data points to be statistically significant, and we've seen a real progress back down away from that 1 hour towards 30 minutes. We had the operating plan guidance published, which we'll talk about later, since the last board meeting, and we know that the target for the coming year is going to be 30 minutes. There's lots of work in hand on this. It's by no means in the bag, to use a colloquialism, but I think we're feeling increasingly confident with the range of work that we're doing that we should be in a good position to meet that target in the coming year, and I'm pleased to see that because I'm sure we're all very concerned about those elongated waits for Category 2 ambulance response times. The next thing I wanted to highlight is in relation to the target to eliminate waits of over 78 weeks for patients who are on the elective waiting list. This is a target that's been set nationally for this year that we're currently sitting in, so all of those waits to be eliminated by the end of March this year. Here in the ICB, we actually set ourselves a target to get within 180 of that, and that's because of the previously discussed difficulties we've got on the complex spine pathway. But I just wanted to highlight that we do have concerns in relation to County Durham and Darlington FT. They've got some significant issues meeting the target they set themselves in relation to this. As a result of that, they've been moved into the Tier 2 process, which is a national way of adding additional support, both regionally and from national support to help them tackle that. Many trusts, including County Durham and Darlington, have been adversely impacted by the recent strikes and regrettably had to cancel some operations and outpatient procedures because of the availability of staff on those strike days. But we're working with the trust to put a recovery plan in place, and I'll apprise future boards of how we're getting on with that. But that's a risk for us in terms of delivering overall our 78-day plan as an ICB. Just in relation to that, I'm pleased to say that we're holding and slightly ahead of our plan around the 2-year waits. So again, I've previously reported that our plan was to get to no more than 30 people, all of them on that complex spine pathway by the end of March, and currently we're sitting at 24. So we're hopeful that we'll get close to 0 on that and exceed the ambition that we set earlier this year. Okay, I think the only other point I wanted to make is that when you look in the pack in relation to the urgent and emergency care indicators, then again, in addition to those ambulance response times, we are seeing some green shoots, I'll put it that way, in terms of our overall performance. And so when you see the report at the next board, which will reflect the performance up to today and so on, you'll see some significant improvements. So not just on the response times, but also in relation to handover delays, in terms of call time responses, and indeed in relation to those waits that patients have been suffering in ED departments when they're waiting for a bed to be allocated. So in the pack you'll see quite a deterioration in relation to that, but during January that's improved. Another final point I wanted to make is about GP appointment volumes. Ostensibly, we've got a good news story in the pack in that we're seeing that yet again we've got a record number of GP appointments occurring. This time it's for the month of October. These data are slightly longer in coming through. So 1.7 million appointments took place in North East and North Cumbria in October compared to 1.5 in September. And there's actually one less working day, although we know that GP appointments occur on Saturday and Sunday, the bulk obviously occur Monday to Friday. But just wanted to note the strain that that's putting on our primary care services and our GP practices, because we haven't seen a substantial increase in the workforce in that reporting period, and had conversation with Neil about this a couple of weeks ago, and there is a huge amount of demand being managed in our GP practices at the moment, and that's causing really significant strain. So whilst it's good to see that they're able to respond to the demand that's out there, it's not without its difficulties, and I just wanted to note that in the board. Obviously there's a large number of quality metrics also covered in the report, and I have my colleague David and Neil over there sat with me. Those are just the highlights I wanted to make. David's going to take the finance slide separately alongside the finance report, but I'm happy to take any questions, Chair. Thank you.
Okay, thank you. Well, we're doing quite well for time, so this is a very comprehensive report, gives an important profile of how we're performing at the moment. So please feel free to dig a little bit deeper into any of the points that Jacqueline's made, or ask any questions. Maybe I could start, Jacqueline. I just wanted to flag up my ongoing interest in patient safety, and noting the serious incident reports and particularly the Never events. I think since the changed organisational structure away from the CCGs, we haven't really properly got a new system in place for this, in that prior to the ICB coming into being, Foundation Trusts reported their serious incidents to the local clinical commissioning group, and there was a plan to investigate and to draw out lessons for preventing similar incidents in the future. And that was under a national infrastructure of gathering data on not just serious incidents, but all errors and incidents that occurred. And the national arrangements are changing and not fully implemented yet. So the whole situation is quite fluid at the moment. And you'll know of my expertise internationally on patient safety, and much of the world is in a similar place, that we have a minority of things that happen in both hospital and primary care that go wrong in some way, sometimes resulting in harm to patients, with the potential to prevent them. But worldwide, there hasn't been a lot of progress in reducing those risks, albeit that the majority of care is very safely delivered. So I think there is the opportunity, given the size of our ICB and the experience that some of our FTs have had, and some of the expertise of people on this board and also more widely in the North East and North Cumbria, to really do something a bit different and see if we can be one of the parts of the country that really innovates on learning from adverse events and incidents. So I just wanted to flag that up. But other comments and questions then from... Yes, please, Mike.
Following on from the back of that, well, I welcome the report, and it's incredibly detailed and valuable. The one thing that I can't see in the quality section is any reference to primary care. So it would be maybe welcome to look at some indicators for primary care in the quality section in particular for future reports.
May I comment on that, Chair? I mean, I think there's a lot of work to do on this report, and I'm pleased to say we've now got a Director of Performance and Improvement in post this month, Lucy Topping, and she's taking the lead in working through how we can, if you like, improve the insight in the report. And my ambition is to create a sort of nested group of reports, perhaps less detail in this report, but the more detailed attachments. And in specific relation to primary care, I've asked that a set of primary care indicators be developed, because I think we've only got minimal indicators in here. We've really only got appointment volumes, DNAs, and sorry, that's the volume of appointments that the patients do not attend, and also how many are being attended face to face. There's so much more we should be measuring, both the sort of quality metrics that you're referring to, Chair, and some metrics relating to the ambitions in our strategy. So working that through over the next few weeks, and you'll start to see changes to the report in the next board reporting period. But I think there's a lot to do, but we also need to sort of manage the size of it. So something else that I'd like to talk to the board about is whether in development sessions we can have a focused discussion on key topic areas to help sort of understanding and driving the sort of insight that we're able to provide in the report.
Just before Sam comes in, Jacqueline, could I just add, we have an item later on data and information. So this is, if you like, a more specific point about board members. I'm aware that access to information is becoming easier. And is there anything that you can say about ways in which board members, if they were interested, could tap into some of this performance data as it's actually happening, and see what the latest position is for the ICB's functions?
I can do, and Graham may want to contact, there's a sort of technical backing to this, but I think in terms of sort of the principle, it would be really helpful if not just the board report, but the supporting reports were openly available to board members, and indeed to members of the public. When I do the presentation later on the Strategic Coordination Centre, I'm going to talk a little bit about that towards the end. So I think we can provide some better formatted reports where the information and the changes and the insight jumps out at you a bit better, but also high-level reports underneath which the sort of detailed reports you can dig into if you want a little bit more information. And I suppose that the final thing I would say is that to support board members as well as providing the data, I think we need to be providing commentary that connects the data to a set of improvement plans and how we're doing against them. So you get that full picture, connecting the strategy and the plan to the data, where we are and where we've said we'll get to, and kind of highlighting exceptions and actions. That would be the sort of vision. Quite a lot of work to do, Chair, to get that fully realised, but we're on with it.
Well, because the summary paper is excellent and you've highlighted it very well, but the detailed presentation or the info pack is quite daunting. I mean, the metrics are nicely formulated, but the amount of detail and seeing the wood for the trees is quite difficult. So maybe that's something that we might want to try and work on. Sam.
Thank you, Chair. different item, which is page 15, elective waiting list, health inequality. So a couple of things on that really. Firstly, I think it's good to note that we're not identifying that we're deepening or widening any further health inequalities in terms of the waiting list growth and treatment. Did note, however, that 25% of all patient records don't have ethnicity status recorded. So a bit of a question, Jacqueline and maybe Ken as well, for the Provider Collaborative, on actually what steps we can do to increase that. The other aspect of the report in terms of IAPT waiting times that we're seeing increase and a growth in the waiting list. Note the actions being taken on that. I do think we also need to make sure that we're monitoring that waiting list from a health inequalities perspective in the same way in which we are doing the acute elective waiting lists as well. So that would certainly be something I think we should take away and look at.
Graham, you wanted to follow up on the point on the data?
Yes, thank you, Chairman. Really, just to build on Jacqueline's point and your question, during my presentation, I'll give an indication of the process that we're going through in terms of how we understand the needs of data, working with subject matter experts, and then to provide a comprehensive and appropriate data response to those questions being asked. Thank you.
Are there any other comments? David, yes.
Yeah, thank you, Chairman. Jacqueline, can you just comment on where we are on performance management arrangements? I know a few months ago you did a very comprehensive paper and actually was setting them up. But given the areas where we need to improve, I wondered whether the actual arrangements were now fully implemented and working fine, or what?
Thanks, David. So, I mean, they are implemented. We are live. We've got a set of oversight meetings with our FT providers set out in the diary. We did our first one. We've got another one this week and another one next week. We've had really good feedback on the initial process in terms of having a really open and inclusive process where we set out the data pack 3 weeks in advance, have a good kind of response from the trust on that, review that, and then really spend the time in the meeting working together on what further actions might be identified. We're then just implementing the kind of monthly touch points with the organisations in between those set piece meetings. So I think in terms of the oversight arrangements with the 11 Foundation Trust, that's being rolled out. I think we need to do a full cycle and then take stock and see where it is. So it's still very early days. I think there's further work to do in terms of how we provide oversight and performance management to all aspects of our system. So thinking about primary care, our place-based committees, which we've had papers about previously, and you'll know are still in the process of being formally stood up. So I would very much hesitate to say that we're sort of fully embedded. I think that's going to take some time as a new organisation, but I think we've set out a good process. We co-produced it with the parts of the system who'll be working within it. And we're also working very closely with NHS England. They signed off the memorandum of understanding we proposed and actually are reshaping some of the ways that they work in response to the approach that we've set out for the ICB. So I'm hopeful it will be impactful and help improve performance. I suppose the only thing I would mention that in addition to the kind of comprehensive approach, there are focused performance management arrangement around specific issues, whether they be the quality arrangements that David leads, where we're able to stand up a responsive meeting to particular issues, and you may want to say something about that, or whether they be performance issues, where we've got the national tiering system, or indeed where they're financial issues, where David works very closely with the organisations to manage those. So it's a blended approach, sort of formal and targeted. Thanks.
Thanks. Joe Corrigan.
Thank you, Chair. You did say that Jacqueline has plenty of time to answer some questions. But I take the point about the development of the report, but the current metrics in the conversation at the minute has a focus on the supply side. And I don't know whether as the report is developed, there's an equal focus on the demand side. So, you know, we can have a
I think that's a good point, and I think it's something that we've historically been poor at. And in terms of demand, we tend to use waiting lists as a sort of proxy for demand, and we know that's not the case. I almost came in on that point in relation to the inequalities point that Sam raised, because I think we're still developing the right questions in relation to inequalities. So it's helpful to know that once somebody's on the waiting list, they have an equal waiting time, but there's much broader questions about where the need is in our population and whether people are adequately represented on the waiting list in relation to things like deprivation and ethnicity. So a lot of work to do, I think, on the demand side. I'll take Joe's point. Thanks.
Can I just return to the question of the longer waiters, the 78 weeks plus and the 52 weeks plus? I'm aware from national meetings that this is a major priority at the moment for ministers and the government, and we're struggling a little bit in that area, as is the case in other parts of the country. I just wonder if you could say a little bit more about the solution to getting those numbers down to the required target.
Thank you, Chair. Actually, we're working with our provider collaborative at the moment to, they're taking a lead on what is a sort of system-wide approach to what's termed elective recovery, returning waiting times for planned investigations and procedures to the national standards. And we would have an ambition, wouldn't we, to go beyond a year's wait and get back to more like the sort of waiting times that we saw a number of years ago. There's a couple of key points you could make. It's quite a complex area, so I suppose a fundamental point is just my mic. Shall I just? Oh, there we go. So a fundamental point is just about restoring diagnostic and treatment capacity to beyond pre-pandemic levels. We measure what we're able to deliver in relation to what we managed in the year 1920, and we're still working to get beyond that in some parts of our system. And so long as the numbers referred exceed the numbers treated, we're going to really struggle with this. So there's a national ambition to get to 130% of what we did in.
Yeah, I don't know whether we just might pause and see if is there a technical problem at the moment with the sound?
I'll just, Thanks, Mike. Thanks, Mike. So a big issue is around capacity, and we're working very hard to look to develop that. And in the planning guidance this year, we're expecting, although it seems quite complex, a new mechanism for incentivising additional capacity. The other area of work is around mutual aid, so where we've got differential waiting times in different parts of our system, getting our providers to work together, and we've already got some good examples of this to ensure that we share our capacity across the region in order to normalise those waiting times across the piece. And then the third area is really about changing pathways and looking at innovative ways of responding to the demand for care. And that's about working with colleagues in primary and community care to think about what can be done pre-referral. It's about redesigning pathways so that they are as efficient and lean as they can be, and we get people rapidly to a diagnosis. And looking critically at our treatment pathways to see whether we're always delivering the right interventions. And the way that we're tackling that is we're establishing a range of clinical networks that look at clinical specialties with involvement from across the piece, primary, secondary and tertiary care, multidisciplinary, to see how we can redesign pathways, and also draw on a national evidence base which we have access to through the Getting It Right First Time team, where we've got examples of optimal pathways and opportunities to focus on productivity. So, for example, making sure that we get the maximum number of patients through any given operating list. So lots and lots of work to do. We're shortly going to set out a plan for the ICB that the Provider Collaborative is leading on to show how all of these different interventions will come together to deliver reduced waiting times and sustained waiting times at least below 1 year for the patients in our population. Thanks, Chair.
Ken Bremner, you chair the Provider Collaborative. Do you want to make any comments on this?
Yep, I'll make a couple of quick comments. I think Jacqueline's given a fairly comprehensive answer to the action that's taking place so far. The GIRFT bit, the getting it right first time, I think we've just had a fairly significant session a couple of weeks ago with the national lead, Tim Briggs, on GIRFT. And I think we had something like 70 or 80 clinicians in the room from around the region. That will focus very specifically on pathways, productivity and efficiency. We've got a lot of data now actually about the variations we have across not just the North East but nationally. And I think we'll be looking to see whether some of that can be actioned quickly to get some immediate benefits from that. But some of these challenges in some organisations are quite deep-seated and quite deep-rooted and will take a little bit of time, I think, to get properly on top of. Essentially, a lot of it comes down to managing our supply and demand appropriately and being prepared to invest sometimes in infrastructure to help improve things, but it's equally important that we transform and change the way some of our services are delivered. So, Liam, there's a focus on the short term in getting some of the numbers through the system, clearly, because we've got an overhang on 78 and 104, as you've heard. But we're also, I think, trying to put some foundations in about the longer term transformation of the way the pathways are delivered.
Yes, right. Press the right side of the button.
right side.
That's it.
Can you hear me now? Okay, thanks. I know we are discussing predominantly around the acute waiting times, but one point I wanted to raise was about the children at the moment, children and young people waiting for mental health services. It is part of Core 20, children and young people's priorities. And I do think that we have an opportunity, whereas an ICB and an ICP, when we've got all the partners here to look at how we can do things differently. At the moment, there are so many children who are waiting on the neurodevelopmental pathway and the impact it has on families, the communities. So what I would welcome is, I know, Jacqueline, you're looking at some of the data itself to see how that could be represented in our reports, but maybe a focused discussion on it to see what could be solutions. We have got transformation coming up for community mental health services, and that does provide, I think, an opportunity if we link in effectively with our third sector, voluntary sector, local authorities and education to really tackle this, because it's something current systems are not going to manage.
Thanks, Rajesh. Jacqueline, you say something about how the pressures in mental health services are being dealt with?
Yeah, thank you, Chair. I mean, I think there's look at this from both ends, if you like. There's a Hello. There's a piece of work to do to set out our plan to tackle these issues, rather than just focus on looking at the data. We can definitely pull better data through to the report, but actually it starts with what are we going to do about what we know is an unacceptable partners in the mental health, learning disabilities and autism community to set out our planning priorities and our plans to address these very long waiting times, including new ways of working. Sam referred to the work we're doing to draw primary care. Is an autism, having a partnership board that's embedded into our governance structure, and through our planning processes in the next few weeks we'll be setting out our approaches to addressing these long waiting times, and then we'll refresh the metrics that we look at in the board report so they connect to the plans we've set out, and we can really hold ourselves to account to see whether we're delivering those. So there's work going on around the metrics, but also linked to our actions to address these concerns.
Thank you, Sam.
Thank you, Chair. I just wanted to really endorse the point made about the opportunities the community and voluntary sector. Claire and I went and visited one of our third sector organisations in our system recently. I was highly impressed, particularly with the work that they're doing with our mental health providers on the community services transformation, and indeed that work's been shortlisted for a national partnership award. And we are also attending the NHS England board meeting on Thursday to present the work in our system on the community mental health transformation. I think we do need to look at that work, which is focused on adult community services, and look to see how we can take those principles into the children and young people's services too.
Thank you. Are there any other comments on this item? Well, thank you very much, Jacqueline. And David, we move over to your finance report now.
Okay. Can you hear me okay, Chair? Coming through for now. So thank you, Chair. So I'll assume everybody has read the report. We do review the finances each month at the Finance, Performance and Investment Committee in detail. So what I thought I'd do this month for the board is simply focus on the 4 main financial duties in relation to the ICB and the ICS for this year, and also provide an update in terms of financial planning for next year, following the guidance that was released in December or late December. I'll start with the first responsibility or duty in relation to ICS duty to break even. So that's the wider system, that's the ICB and the foundation trusts in the financial regard. So you'll remember in November when we met that I highlighted across the ICB and the ICS that we were forecasting break even, but we had risks around £39 million that weren't mitigated. And if they weren't mitigated, that would put the delivery of break even at risk. You'll also recall that we were doing a lot of work with partners, but also with NHS England around some of those risks that you could quite clearly argue some of them were not necessarily within our control. I'm delighted to share today with the board 3 key developments since that last report. So first of all, NHS England have for this year agreed to allocate us £19.9 million of non-recurrent funding towards those pressures on the proviso that we deliver break-even for this year. Working closely with Foundation Trust Directors of Finances, Chief Execs and ICB leads, I have now agreed a financial plan with all NHS partners that delivers an ICS break-even plan and reduces those risks down to a minimal level. That plan has been shared with and will be going to the Finance, Performance and Investment Committee in a bit more detail on Thursday, and we will talk and discuss that there and then, but it just seemed apt to bring it to the board today. The revised plan will require some organisation forecast turns to change slightly, but what the plan does do is it reduces those organisations with the risk of falling into a deficit. The plan does include the ICB reverting back to a £2.6 million surplus rather than a £5.6 million surplus, which you'll recall we did mid-year to ensure the ICS could still break even. In addition, the NHS England have made us aware that we will receive an additional £17 million of headroom around capital, so effectively what's called additional CDEL cover, which allows us as a system to spend more money on capital, of an extra £17 million if we break even. So there's an additional carrot there, if you like, to make sure that we can achieve that break-even position. Our actual capital limit is around £187 million each year, so that's quite a lot of money for us. If I touch on the ICB duty to break even, I did report before about the forecast outturn reducing slightly. I've also highlighted in the report the pressures that the ICB was facing around independent activity, prescribing pressures, and packages of care. So as you can see, we've managed to mitigate some of those as part of the overall plan for the ICS. I haven't, though, yet given up on seeking additional funding from NHS England around independent sector activity. The latest forecast for the ICB is that independent sector activity will grow from 1920 to 2023 by £25 million. That's approximately £20 million in ophthalmology and around £5 million in trauma and orthopaedics. And that's good because that's helping with our elective work, but the way NHS funding works and how we've been supporting our foundation trust around ERF just made it difficult to manage the money. So I'll continue to seek that from NHS England, which I think is only right and fair to do so. In terms of risks going forward, as I say, in terms of delivery for 22-23 for Touchwood, I think the risks have now reduced to a minimal level, and we are working closely as a system to manage those risks that may pop up between now and year end collectively as a system. I'll just touch on capital briefly and running cost, Chair, if that's okay. In terms of capital, as I say, we have a £187 million CDEL limit. We're not allowed to exceed that as a system. We're currently forecasting, or in the report, an overspend of £13 million. I fully expect by year end, given that this is effectively managed on a day-to-day and month-to-month basis by the provider collaborative, and we get assurance from them that that will actually achieve break-even, if not better, on that limit for two reasons. One, because there will be some slippage, and secondly, because one of our foundation trusts has a retrospective bid in for £23 million of CDL funding for this year, and the noises are quite positive in that regard. So on two fronts, I think we can be confident that we should be able to live within our CDL limit for this year. And then on running costs, we do expect our running cost that was mentioned previously. Our running costs we do expect to be around £2 million under this year. So that does help us and put us in a good place going forward. But we obviously cannot take our eye off the fact that ICB running costs are never increased for inflation. We don't get funding for the pay and board and the likes. There's always a year-on-year pressure in that area. So that's 22-23, Chair. I'll just provide a brief update on 23-24, which obviously will go in more detail at the Finance Committee. But just to share you some key points on top of the points that I shared. Am I back? Mm-hmm. There you go. Press the button again. That's the trick, I think. So a few points in terms of 23-24. I think it's fair to say that 23-24 financial planning to achieve a plan of break-even or better is going to be extremely challenging for the. Shall I just speak really loudly? Try and come a little bit closer, DC. If not, we'll switch the mic. Yeah, I'm back. It's okay. So we are working closely with system partners in terms of production of financial plans, including system and ICB planning leads. What I would say is that the draft plan is due in February. The final plan is due in March. They're very tight timetables, but we have put in an infrastructure and a framework that allows us to do that with our partners. The allocations that we've received, they are extremely complex. We have something like 30 documents of financial guidance to go through. However, I have to say it's still simpler than some other previous years, so we should be thankful for that. In terms of growth funding, I always think growth funding is a really key instrument in terms of financial health for a system. It's like the lifeblood is growth funding. We have a budget of approximately £6.5 billion. Our growth funding for next year will be below average. It will be 2.92% if you compare like for like. Nationally, the average is around 3.4%. We receive less because we're deemed to be overfunded, and our population growth is lower than many other parts of the country. So that in itself creates a pressure. But if you think about a like for like increase of 2.92%, and if you think about the inflationary pressures and other pressures that we face as a system, you can see that doesn't leave an awful lot in terms of anything left over for anything in terms of investment. It will be extremely challenging. Not just because of the growth, but because a lot of our organisations, including the ICB, have what we call an underlying deficit. That's not unusual, but what it does mean, it puts additional pressures in terms of being able to produce a financial plan. I'll just finally touch on two areas which are quite large areas in terms of funding changes from last year to this year, Chair, if that's okay. The first one is elective recovery funding. That increases from £105 million this year to £140 million. So that's a good £35 million increase. We will be expected to increase activity by around 9% year on year. So that's quite an ask in terms of extra activity. And bear in mind what I just said before about independent sector activity had grown by £25 million from 1920 to 22-23. So already we're spending quite a lot of that money, if you like, in advance. And the last one I would talk about is COVID funding. COVID funding, which has been a specific allocation to the system, is reducing. Last time we got, I think it was something like £125 million last year or this year. That reduces to £25 million next year. That's a significant reduction, which will impact on a number of organisations that are still dealing with the aftermath. I'll leave it there, Chair. I just want to give a quick update in terms of where we are, and I'm more than happy to take questions.
Thank you very much indeed, David. Very clear, comprehensive. Everybody understands it, and thank you very much indeed for flagging up some of the risks in particular, which we'll be returning to in future meetings. Moving on then, apparently the microphone fading is because the wireless connectivity is fading, so we'll see what we can work out in the break. But just carry on because it will come back in again. So Jacqueline, now this is the integrated care strategy. This is an important document which we will be returning to in future meetings, but it's to really give you a first opportunity to hear about it and ask any questions, seek any clarifications, point to areas where you think further work's needed. As you know, it's one of the statutory elements of the whole integrated care system model that was in the legislation, that the integrated care partnership, which is our partner organisation, has to produce an integrated care strategy in conjunction with the Integrated Care Board, with the board, our board, being required to lead the delivery of it. So that's where it kind of fits in. It's a key document, it's a key strategy. The impetus in developing it further and working it up is a joint one between ourselves and the Integrated Care Partnership, but the lead on implementation is with us, the Integrated Care Board. So Jacqueline.
Thank you very much, Liam. And yeah, I'm delighted to be bringing this final version of the Integrated Care Strategy here to the Integrated Care Board this morning for adoption. As Liam described, it was developed and approved through the mechanism of the Integrated Care Partnership board, of which we're all members, and it was approved on the 15th of December, and we did publish it on our ICB website at that point. But we will be formally launching it publicly today with a kind of public-facing rebranded version of it and a range of communication assets so that we're sharing it broadly and widely. I think there are some press activities and so on happening today, and hopefully it heralds the start of many more conversations. So I'd just like to say a few words about the strategy, if I may, Chair, and then, of course, happy to take any comments or questions. So I believe that we've managed to create a strategy that sets out clear and ambitious goals for North East and North Cumbria's health and wellbeing. We've described our vision as better health and wellbeing for all, and we've set 4 really clear leading goals for the health and wellbeing of our population. So firstly, that we want to see people living longer, healthier lives, that we want the outcomes of people's health and wellbeing to be fairer, that we want our children and young people to have a better start in life, and we also want to improve the delivery of the health and care services that are provided for our population in the region. And those 4 headline goals are underpinned by 5 really important enabling goals, and they are around, first and foremost, the workforce, so that we are able to develop a skilled, sufficient and compassionate and empowered workforce. So a whole load of commitments around workforce as a key driver for delivering our vision and our goals. A second enabler around working together at place and at neighbourhood. So that's really around that agenda to make our services work more effectively together, often captured under the term integration, but perhaps a term that's not so well recognised by our public, but really key foundation stone to enable the delivery of our goals, to recognise that prime importance of working at neighbourhood and at place. Thirdly, an enabler around improving our co-production approach, so that we really are not just involving patients, the public and our stakeholders in everything we do, but we're threading into all of our ways of working a truly joint development process, again what we term co-production. Fourthly, an enabling goal around making the very best use of our resources and protecting our environment. We just heard both the opportunities but also the challenges from David there in relation to the funding that's available to us. So absolutely critical that we use our resources in a way that reinforces all of the things that we're trying to achieve in those 4 top line goals. And finally, an enabling strategy around innovation and learning, adopting the very best in terms of the outcomes of research and development, developing innovations ourselves, but also we've adopted this term of becoming the best at getting better. So developing a learning system where rather than having some assets that are available as and when, we really, again, thread that approach to being the best at getting better through everything we do. So those are the expressions of our top line goals. Underneath these, we've set some very measurable goals, and I'm pleased that these goals, whilst being ambitious, are also realistic. Some real significant wrangling in the system to land these things right. So an example would be the commitment we've made to reduce the gap in our ICP in terms of our and the England average for healthy and total life expectancy. Something that sadly has moved backwards during the pandemic, so worsened, and we've made a commitment to turn that around and improve it between now and 2030. A really ambitious goal that will need a whole range of really significant actions to take effect in order to achieve. I won't go through the detail of the strategy, it's there for you to see, but I do want to say that I think whilst the challenges are great, what's become clear during the production of the strategy is that the opportunities to improve and the commitment to do so are even greater. And one of the things I'm most pleased about in relation to the strategy is that it was a real a group effort, if you like. We had the very broad range of stakeholders involved in the production. Elements of it were taken away into our system, so our directors of public health really owned and wrangled through the development of our population health strategy. We were one of the few integrated care partnerships to publish a draft halfway through the process, and we had over 400 bits of feedback on the basis of that draft. And if you sit the draft next to the final strategy, you can really see the changes that we made. We brought through a whole extra goal around best start in life, because that was one of the strong bits of feedback we had, that although you could see the commitments to children and young people, it just wasn't strong enough and it needed to be there in the headlines. There are other examples I could go through. So I think, you know, we perhaps would have liked more time to really embed the co-production, and we talked about that during the production, but we did take the opportunity to build some partnerships. And so what I like about the strategy is it really feels like it's owned in the system. It's not a document that a small number of people have written in a dark room. So as I mentioned, today marks the public launch, and already we've started the very difficult work of delivering the commitments we've made in the strategy. In terms of the formal process, there's a requirement that we as an ICB develop and sign off a 5-year forward plan. The timelines around there is that we have to publish a draft by the end of March and then sign off a final version by the end of June 2023. I'll come in a moment to David's question, because I think this is the bit that you were asking about, David, isn't it, about the production of that detailed plan, and how we'll make sure that that equally is co-produced and addresses the wider determinants. So we've already set out a process for that. We've gone beyond the national guidance, which is helpfully, I think, quite minimal and permissive, and lets us set out our own approach. Essentially, if you think about those 9 goals, the 4 top-line goals and the 5 enablers, they are the chapters of our 5-year forward plan, and we'll be working through detailed and measurable milestones and actions that we will undertake to deliver the commitments we've set out in the strategy. But the other way that we're working on the strategy is kind of geographical. So we're also going to refresh a place-based plan in each of our 13, soon to be 14 places. We've developed a template in discussion with our places about that, and we'll be working with our place leaders to develop those plans so that we've got that local interpretation and commitment about how we'll deliver our plans. And we would expect at every place that engagement with the wider sector will be taking place. The second thing to say in terms of the wider determinants, David, is that we're also doing some cross-ICB big pieces of strategic work around the wider determinants. An example I draw out is the work that we're doing with the housing sector. We made a commitment in the strategy to work closely with the housing sector because it's so critical for the health and well-being of our population. And during the development of the 5-year forward plan, we will be developing a plan around how we're going to work together on housing and health. We've set up a subgroup with our local authorities under the partnership arrangements we have with our directors of adult social care, and we've started to think through and started to try and learn from other parts of the country who are already working on this about the areas we'll focus on, but they're likely to be in relation to supporting people to live independently for longer period in their home, thinking about how we work together as an economy to address the needs of people who have complex health needs and need housing that accommodates that, and also thinking about how we can pull together to help people address issues in terms of cold and damp in their homes, which we know are so critical for health. So they're just some examples we're talking about. There are other areas we'll be working together in terms of the wider determinants. The other thing that we've made a great commitment to do is around thinking about how, as anchor institutions in our health economy, health organisations can contribute to managing wider determinants by creating good job opportunities, working with young people to draw them into health careers, and also being thoughtful about how we spend our health pounds in our local health economy to contribute. And then we had the great example earlier, didn't we, of the work that's been done to develop jobs through the pathology development that's going on. So lots and lots of examples of how we'll be addressing the wider determinants, both at local level and then strategically across the health economy. So that concludes the sort of remarks I wanted to make about the strategy, but as ever, happy to take any questions and delighted that the mic worked for the entire element of that. Thank you, Chair.
Can I just ask David Thompson if you have, if we've covered your points, or I think there were two other points you raised that you might want to put again, and Jacqueline can respond.
No, I think you have responded. You did mention about the local authority plans being included and so on. But might I ask one supplementary, if I may?
Yes, please.
You mentioned quite rightly about place and neighbourhoods. Might I ask about the primary care networks? Has any work been done to measure, evaluate their effectiveness, the differences they're making, the support they're still receiving from GPs and so on? Because it seems to be an integral part of, of the work, especially with the local issues. So how are they progressing? Do we know that they are succeeding in the manner in which it was intended?
Shall I ask Neil to comment, and then you can come back?
Either Neil or David, perhaps, is also taking a lead on the... Yeah.
So I think it's fair to say that the primary care networks are in various different stages of development, and we mustn't also forget the GP federations as well that are still around, that do support a lot of the primary care networks across the patch. We have done some work with our primary care networks to encourage them to form a collaborative across the North East and North Cumbria in order to spread some of the best practice and some of the learning across sites. One big piece of work that we will have to make progress on in this next year is the fuller stocktake, in which there are a number of suggestions of how primary care networks form integral part of neighbourhood teams that have both responsibilities in managing on-the-day demand, access to primary care, as well as some certain health promotional work. So once we get into some of that work, there'll be some very specific metrics that we'll be looking for primary care networks to make progress on. I think we'll be able to update board more in future meetings. But just to remind everyone that primary care networks are not large organisations. They do not have a great deal of infrastructure or support. I think facilitating that and coordinating that could be an essential role for us as an integrated care system. And again, we'll be looking at ways to do that in the months to come.
Dave, did you want to add anything?
I think the only thing I would add to it, I'd probably agree with you, David, in what you're saying, that they're integral to the development of the plans and the delivery of them. But Neil's point, they're not there to do everything. They're not the panacea for everything. We need to make sure we've got a whole raft of things working locally to make sure we deliver our ambitions.
Thank you. David Stout.
Yeah, Jacqueline. Right, okay, you can hear me. Yeah. In doing the forward plan, do you have adequate resource assumptions for the 5 years or any of the years to enable you to do a decent bit of work around it.
Just to clarify, David, are you talking about the resources to develop the plan or the resources to deliver the plan in terms of...
The financial resources available for new growth going into the system, where that's required.
I'll ask David to join me on this, but I think we don't have a fully detailed financial plan set out for us, set of allocations across the 5 years. I think we've got some broad brush information, but we're not looking to set out a plan at the level of the detail that we would normally in a one-year plan. So, there'll be 1 year in real detail, which effectively the operational plan that we're developing alongside, we've chosen to make year one of our 5-year plan, and then we'll develop plans for the sort of headlines across the 5 years, and then refresh it on an annual basis as the full detail of the financial applications becomes clear.
Great. Could David comment on, have we got any assumptions for years 3 to 5?
Yeah, I can come into there, Chair. What we have is we've got allocations for 23-24 and 24-25. 24-25 is at a macro level, but we can soon take those numbers and interpret that, so we can do 2 years. What we do know is that NHS England basically use this commentary, which is we're on a glide path. This is their terminology, not mine, which is, if you think about the level of money we've had from COVID, which was a sharp spike, we're on a glide path down to the assumptions that were built in around long-term planning type arrangements. Right. So we can make some really broad brush, but simplified adjustments to what our assumptions where we think we're going, where we're heading. You know me, I'll try and manage expectations here without being too pessimistic. Next year looks tough. 24-25 look worse again. Happy days. And there's this glide path. So it is going to be challenging, unless there's a change around additional finances for the NHS. We are going to have to be more productive and more efficient and work more closely as a system and think about innovation as we never thought before. So there's a lot to do, but part of my role is to make sure we've got a strategy for 5 years across the system that sort of says, based on these assumptions, this is what we think we can deliver, and then we take from there.
Thank you. Tom.
Thank you. Just thinking a glide path sounds a lot nicer than it probably is, actually, isn't it? So thank you, Jacqueline, and everyone who was involved in producing this, actually, because I think it's extremely challenging to do a report of this nature or a strategy of this nature that covers such a big geography with so many different stakeholders and moving parts. So I think to come up with something that is so comprehensive and ambitious is really impressive. So, I think it's a great piece of work. I guess the thing that I always reflect on, particularly at this board meeting, is that the point of this board ultimately is to deliver against this strategy. So how are we structuring everything we're doing today based around this strategy moving forward? Can we really say that we're looking at these ambitions as we develop the board and its functioning moving forward? So that means, in the way that we monitor performance and the conversations we've had already, how we look at our finance arrangements, do they marry up with, and do they illustrate that we're making good progress against this strategy? And, so my ask, I guess, moving forward is that we do try and structure what we're looking at this board around the ambitions we've laid out here, so it doesn't just end up being one of those nice, well-written documents that sits on a dusty shelf somewhere.
Thank you. Sam, would you like to pick that point up?
Yeah, thank you, Chair. And Tommy, you stole the point I was going to make, which is this really becomes our true north now. It's our plan. It's the whole purpose of the integrated care system, the integrated care board, and the integrated care partnership working together through the system is to deliver on this plan. Now, I think we need to be realistic. We want to review it at certain points to check progress, and also we're still working in a fairly volatile, unpredictable environment, and therefore priorities may well shift and change. However, we now need to be structuring what we do, how we do it, how we measure, how we assure ourselves against this plan. So I would expect over the development of the Joint Forward Plan, we would also be looking to make sure that our work of our committees are aligned, but also right down to our individual objective setting process in the ICB. I also would I guess expect that our partners across the system will also be the same. Now, this strategy does not replace individual organisational or health and wellbeing board strategies, but it does complement it and it does provide those overarching goals. So I think we will only do this if we get really strong alignment with the actions of everybody across our system, wherever they work, whoever they work for. And so I think we need to really think through carefully how we achieve that, how we make sure that we monitor it here at the board, but also that we have this as our true north. So absolutely support that. The other final point I wanted to make was around the resources, the money particularly, because I think anybody looking at delivery of public sector services at the moment, or even independent sector services with inflation, with the unpredictable kind of nature and volatility of the economic situation, we can paint quite a bleak picture, I think, on that. Having said that, we know that when we look at the resources across the system, and if you just look at our workforce and you look at, for example, what we're spending on agency costs across the system, £130 million, you can see that actually we do still have some opportunities in the system to make better use of the resources that we've got, whilst recognising the challenging circumstances within which we're working. So I think that we still do have some opportunities there, albeit, as David said, it is going to be challenging. We'll need to keep that under review.
Thank you. Rajesh.
Thanks, Chair. Thanks, Jacqueline. I think my points both have been addressed by Tom and Sam, actually. It was about how we reflect some of these ambitions into the performance reports, the quality reports, and of course, that might even give us a steer about how we manage the money and people. But what I would like just to add further to what Sam was saying was, it would be useful while you're looking at how we distill all this information together for board members as time progresses, for us to get a golden thread about which are the key ones that we really need to concentrate on. Because, I mean, we all know we have some of the best health services in the country with some of the worst outcomes. Now, there must be something we can do if we can focus on the right areas. So that would be useful if that came through. And I know it's going to take some time for us, our systems to mature and understand, and that your question, Salim, about the data and all is crucial to that. But that would be useful for me as a board member when the papers come to say, okay, this is an area for further focus or discussion.
Sam, would you like to comment on that?
Just that I absolutely support that, and I think we'll do some thinking on that, and hopefully colleagues will see that reflected back in future board papers, but we'll certainly pick up some conversations outside of board as well to help us with that.
Joe.
I've written 4 quick points, if I may. I mean, the first is, and Jackie waxed lyrical about how the document changed from the initial draft to the final draft. I have to say, partners in Newcastle really welcomed just how much of the feedback was taken on board in the final draft. So really commend planning colleagues, and I thought board members would like that to hear that feedback. Secondly, the strategy document. Many interesting groups will sort of pick it up and look for their mention in the strategy document, but I think what is clear that those groups who are not mentioned, it's clear that the most disadvantaged and excluded in our societies, you know, will not go unnoticed and remains the attention of this document. And certainly in terms of the support and goals in section 4.6 and you know, the inclusive health in section 6.3. I mean, that position is immensely clear. I have to say, my own bias here, and I would love to see those suffering interpartner violence and domestic violence feature in the report. But as I've already said, you know, it's clear the most excluded remain a focus for us. My final point, or my penultimate point, we know the economy will recover. It's just a matter of when, but we do know that as economies recover, that actually there's a huge risk of health inequalities actually widen, because those in most have the most resources access the opportunities of a recovering economy. I think we must be guarded against that. And my final point, again, about the delivery, it has to sit alongside the opportunities of the recent devolution agreement, and clearly, you know, the plan itself sort of sings in that regard. Thank you.
Thank you for those points, Joe. Sarah.
Thank you, Chair. Thank you, Jacqueline, for a very thorough paper that sang to my heart as I read it. My point was just going to touch on prevention, because I was always very impressed. It was one of the first things that we discussed as we came together as an ICB, that prevention was one of our key priorities. And I know that we've had issues that are preluded and kind of deviated our attention to being more reactive, as we tend to be in the NHS, to provide acute care. And I can see threads of prevention, which obviously will help with population health, health inequalities and so on within this paper. But as a board member, I would like to see a more focused approach to prevention. And I know there's lots of work going on across the ICB about prevention. So if you could just touch on that, I think that would be really useful.
Neil's going to volunteer for that.
I can pick that up. This month, February, sees the first meeting of our Healthier and Fairer group, which is a cross-sector group that will report into our board, and underneath that, one of the main work streams is prevention. As you've said, we've made really strong inroads into prevention over the last few years, with collaboration of all of our systems, previously CCGs and local authorities across the North East and North Cumbria, and we've continued that work in reducing tobacco consumption, strategies on obesity and alcohol reduction. There was you may have seen in the press, NHS England are really launching improved support for secondary prevention. And we've got some strategic networks looking at secondary prevention for cardiovascular disease, so for AF case finding, atrial fibrillation case finding, which is a irregular heart rhythm, which can increase your chance of stroke, and also wider prescribing of statins, which are cholesterol-lowering medicines. So I think a lot of this work will become a lot more apparent to board when we start reporting the work of the Healthier and Fairer group, which we'll do in probably quarterly.
Thank you. I don't see any other comments, and we're near to our break now. So I'd like to thank Jacqueline, go on.
So just briefly, Liam, I just wanted to make one other point in addition to those that have been made around the delivery of the strategy, which is to say that, in case it's not obvious, in addition to the 5-year forward plan, kind of getting into the detail of the what and the how we will deliver, it will also give much more detail about how we'll organise ourselves as an ICB to use our resources and our ways of working to support the delivery of those objectives. And some of that work's starting already. So we have a wide array of clinical networks and strategic programmes. I've got work going on this week and next week to just look at how they align and cover all aspects of the strategy and how they report into our governance structures. It's a bit, I know, kind of governance, but just to give assurance to the board that we're really looking at all of our delivery mechanisms to align them to those top-line goals in the strategy. So as well as things like the integrated delivery report changing shape, so it will follow the structure of the goals, our kind of ways of working, governance, where we put our programme resources to help support the system to change and improve, is all being aligned to the delivery of the strategy. Thank you.
Okay, it is break time now. We have to be back in our seats to stick to the timetable at 10:30, but tea and coffee's outside, and we'll see you in 20 minutes' time. Live now. We're back to the meeting on 31st January 2023 of the Integrated Care Board for North East and North Cumbria, resuming the agenda at item 7.5. And this is one of the items that we've left a longer time period for, to discuss the use and development of information systems for the work of the ICB. And Graham is going to make a presentation, and then we'll have some time for questions and discussion.
Thank you, Chairman. So, as the Chairman's outlined, this is a description of the evolution of our data and information services that will support the work of the Integrated Care Board. Towards the latter part of the presentation, I will refer to some questions that are within the pack, the board pack, a specific set of questions that the Chairman has set to really understand the data capabilities within the existing infrastructure, where we have data and the tools to present that data, and also where there may be some gaps and area for further improvement. If I can just start first of all by just setting the context for our future data strategy. As far back as 2019, the government, or the UK government, presented a paper regarding the National Data Strategy. This described a series of services that all government departments would be mandated to develop in order to improve data, its usage, and hopefully improve the UK economy as a result. Each government department was asked to respond and create its own version of the National Data Strategy. And in 2022, the Department of Health and Social Care produced its first data strategy, which was entitled Data Saves Lives. And it's that strategy that we are going to build some of the foundations of our ICB data strategy. In terms of data and digital, in 2020, the emerging integrated care system developed a digital strategy which was produced and published on the ICS website at the time. This was well in advance of both the national and the Data Saves Lives strategy, and also in advance of having an integrated care system strategy. And we've heard from Jacqueline Myers earlier about the recent publication of the Better Health and Wellbeing for All strategy and its publication and its public publication today. And what we now need to do is to refer to the sections within that strategy to ensure that our data and digital strategy is complementary and fully aligned. So there's an element of reverse engineering to a degree. So our intention is to, by the end of March this year, to have a combined digital and data strategy, referencing the key elements within the overarching ICS strategy, but also emphasising the key enablements regarding both data, digital and technology. We'll also then use that strategy to input into the 5-year forward plan. So there's a vertical alignment of our big ambitions and also the enablement elements. In addition, we've recently been advised of our successful bid to be one of 11 sub-national secure data environment regions. And this is a really big opportunity for our region to use data in the context of research to improve the health outcomes for our population. So again, everything seems to be flowing in a nice direction at the same time. However, we also need to learn lessons from the past, and many colleagues around the board and listening in will be aware of some programs of work that perhaps didn't develop or deliver the outcomes that they were originally intended. Care.data being one. This was a really ambitious program to integrate both health and care data, but perhaps hadn't really considered some of the pitfalls that needed to be understood. And we are learning as a health learning system, not just learning within our own system, but learning from others. And I think Care.data has a number of things that we can take on board and use to our advantage as we develop our own data strategy. For example, making sure that the citizen has the right for anonymity, also the option to opt out of providing data if the consent isn't there, and making sure that there's clarity in process and the use of that data. So transparency in what we do will lead to trust, and it's trust that we will build our foundations upon. A phrase that our chief executive uses quite often is trust comes in on a tortoise and leaves on a racehorse. So we really need to embrace the use of data and gain the public trust in its use cases. But data on its own is meaningless. What we need to do is take data and consider it in context. So where we can provide the context of a healthcare system or a process using data with a subject matter expert, and that data will then lead to insight. Data in context leads to insight, and it's with insight that we can then take an action. And it's action that will make the difference. So how we then use that data in context to deliver a change, perhaps a change in a process or a service or a behaviour, and they will be the fundamental components of our strategy. Recently, the board had the real opportunity to listen to Professor Mark Britnell from KPMG, who talked about the key characteristics of a high-performing integrated care system. And listening to many of the updates this morning at the board, I think what I took on board is we have many of those characteristics already, but not letting perfection be the enemy of good. There's much more to do. But I'll just point out two characteristics that are relevant to the data conversation. Making sure that we have a solid and robust digital and data infrastructure. So building on those installed assets, reusing those data services and assets as best we can. Ultimately, this is about using taxpayers' money wisely. So we have a lot of infrastructure already. It may not be perfect everywhere, but to build on those assets is one of our ambitions. And then using that technology and data in the context of a learning health and care system. And it's how we then use that learning to feed back from the data, from the actionable insight, and then making corrective changes to improve what we do and how we do it. So again, many of those characteristics will be built into the processes that we are developing. In terms of how we architect the data, and there is a detailed diagram behind these 6 components, but it's about making sure that the data sources exist, and we don't have the answers to every question, and I'll refer to that at the latter part of the presentation. But where data exists, what's the frequency of provision? When we receive it, how do we manage it well? Can we make sure that it's stored safely and securely? We're in a world now where data and cyber threat is an increasing challenge. So in order to gain and maintain trust, we need to manage data in a secure and appropriate manner. We need to govern it. We then need to visualize it. And quite often, a spreadsheet or a diagram or a pie chart doesn't really tell the story. So it's creating the data in context with some narrative that really allows people to understand what the data is saying and what we then need to perhaps do. And then using subject matter experts from the various domains, be it performance, finance, workforce, operations, and then use that alongside experts in data to work as a partnership. So as I said, these high-level indicators overlay the key architecture that we have behind the scenes. And this is the actual architecture that we have available within the North East and North Cumbria for our current operational and population health data. But to the right-hand side is the architecture that we're now proposing that will be the secure data environment that I've previously alluded to. But data and its foundations are the cornerstone of an integrated health and care system. And data that we receive is the product of the services that we deliver out in our broader system. And therefore, we need to make sure that our organisations around our health and care system see technology and data as an investment and not just a cost. If we can invest appropriately, then we can see significant benefit in joining health and care data together. Provider digital maturity, how advanced those providers are, is a key and rate determinant. By definition, as an integrated care system, we will only be as good as our weakest links, and therefore it's incumbent on us as a system convener to make sure that we level up all of our organisations as best we can, but also allow the organisations to see the true benefit of data and technology. So they are the essential building blocks. Again, on the premise of utilising installed and existing assets, working alongside our colleagues at the North of England Commissioning Support Service, we are intending to utilise their business intelligence and analytics service. There's a 5-tier model that's illustrated on the diagram, but working in conjunction with subject matter experts within the Integrated Care Board, we will create what we're terming the ICB Data Services function. And this will be a combination of subject matter experts, domain experts, working alongside data experts in a partnership to ensure that we, first of all, understand the questions that are being asked, we can refine the questions, then work together to understand the answers and the actionable insight that then will be a function of those conversations. But data, technology on their own require people. And we've heard a number of conversations today on how we make sure that people understand the data that they are reviewing or accessing. So one of my ambitions would be to have everybody within the Integrated Care Board and the wider system having a minimal level of data competency. You know, some understanding of what they're seeing and what they're doing and how they access that data, to make sure that we are investing in our people and people have the skills necessary to do their relevant jobs. As well as the basic and essential components, we'll also create a function that invests and increases the analytic skills of our analytical experts and business intelligence teams in order to make sure that we are driving from good to excellent in terms of our service provision. It's also incumbent to make sure that we can try and provide a degree of self-sufficiency. So again, not just the analytics teams, but the general consumers don't have to keep going asking an expert. They will be able to self-serve and access data where that's necessary and appropriate, but with levels of training. And I know there was a question in the earlier part of the board about how perhaps board members could access data. Well, we've got a lot of data, but on its own, it may not tell the story that people are wanting to hear. So therefore, we provide some degree of understanding and knowledge sharing, and then the tools to access. But let's not swamp everybody. It needs to be focused and appropriate for the consumers needing to access. And the final point is that we're working alongside NHS England to produce an academic programme that will allow us to implement more of a professional development for our analytics teams across the system. Now, there are elements of this already in existence around our region, but this is potentially a blueprint that the North East and North Cumbria ICB can create that other parts of the NHS in England could then possibly follow. So it's early days, but we have been identified as a potential vanguard in developing this programme of work, again, illustrating our investment in people. In terms of what we want to do practically, and it looks like the graphics have been slightly corrupted on there, but the intention is within the Integrated Care Board is to create an intelligent client function or a council. This will be a collection of subject matter experts that meet on a regular basis, working alongside analytics experts under the guidance of my recently appointed Strategic Head of Data Analytics and Insight. So there will be a group created, a council, if you will, that will allow us to understand where data needs to come from, the key questions being asked, and how we can then prioritise which part of the service needs to take preference over others, because we do have finite resources and it could become a bit of a tsunami if everybody gets what everybody asks for. So we need to create a process around that. And indeed, the challenge questions that the chairman has posed that I'll refer to shortly has followed this approach, understanding the question and then working with colleagues to identify if the data exists and what the data is telling us. So that data service will be at the heart of this particular process, working in that partnership arrangement as I've described to understand the question and context, then ultimately derive from that data and its context the action that we need to take. And that action could be a change in something that we do within our broader system. It could be a clinical practice change, or perhaps it could be a nudge to our population, some form of insight that we've derived working with some technology to maybe change the behaviours of how people interact with health and care services. Now, we're not going to get this right first time, but it is about looking at how we move from good to get better, then become the best. We want to be the best at getting better. So in terms of the questions that are within the pack, and there's a lot of detail in the pack, and it could take quite a while to go through all of them, what I'm proposing to do is to go through 3 of the 10 questions, the questions that are greyed out again.
You want me to just say a word about the context, Graham?
Absolutely,
I will do. When I knew this item was coming up, I was quite excited about it. And, but my long-standing frustrations with NHS data relevance and quality bubbled to the surface. I know we're in a much better period now, and Graham's shown us what the opportunities are going to be. But I think over the years, I've always felt that the NHS routine information systems could not answer questions that I needed for making decisions. Very often, the data you did have was a proxy for the truth. You measure something that threw a vague sort of light on what you'd really like to know, but sorry, you couldn't know what you really wanted to know. And I think we're getting closer to be able to crack that problem. So as a challenge to Graham and his team, one evening I wrote out 10 things that I'd like to know more about. Generally, how many people have got this illness, where are they living, how well are they doing, are they being treated, are they generally, are we better or worse than anyone else, are we getting better over time? And I'm sure you might come up with different ones, but if you do get a minute to read through this paper that I wrote that's in the board papers, it might trigger some thoughts of your own about where we are. So in the available time, Graham today can't go through all 10, but he and his team have done a great job in showing what would be possible with 3 examples from the list of 10.
Thank you, Chairman. And what I will say up front is the data that's going to be presented, I'm not the expert in understanding what that data is actually saying, but I'll do my best. The one thing that I would advise is, alongside the illustrations, a narrative would be really helpful to explain, in layman's terms or layperson's terms, what the data actually means in context. So, as the Chairman's mentioned, there are 10 questions. In questions 1 through to 5, I'm going to be focusing on diabetes and incapacity and frailty. And then on the latter 5, in terms of the smoking-related disease and what we're doing regionally. Just by illustration, of the 10, we do have quite a good understanding of, do we have the data and do we have the tools to present? I would suggest there's approximately 60% compliance level. So clearly there's still a little bit more to do. But the 3 that I'll focus on include, as I say, diabetes, frailty, and then tobacco-related illness. The good news is within the diabetes question, we have been able to answer all of those challenge questions. So we do know that in the region there's 213,000 people. This is data as in January of 23 of this year. 7% of our population, 213,000 people, have diabetes. Many of those have a prevalence that's linked to their age, their sex, and levels of deprivation. We can see the current 13 places in the histogram below that headline data. We also know that 7.3% of those patients live in our most deprived areas and 5.7% in our least deprived. Of those diabetes conditions, there are 9 care processes, and we know that 28% of all adults receiving diabetic care have all 9, and there's about 57% have at least 8 of those care processes. So a good level of data already exists. Of those diabetes patients, 3,200 were admitted to hospital with a diabetes primary diagnosis, 950 of which had some further complications. Those complications again link in the bottom left histogram to deprivation, comorbidities, learning disabilities and some elements of mental health. And we can see again through the place-based graphics the prevalence by place location across our entire geography. So again, a decent level of data, and as I said at the beginning, I'm not the expert on this subject, but you know, we can definitely drill into this as necessary. In terms of frailty and the data relating to that, the one thing that we were unable to answer the chairman's question was about how many people live alone, but we've got a good understanding of the broader questions, the numbers and their ages, etc. So 67,000 people aged 65 or older have moderate or severe frailty, and that was data in December 2022. 10% of all people aged 65 that relates to. 9% are men and 12% are female. And again, by place, we can see the prevalence from Cumbria on the left-hand side through to Hartlepool on the right. The right-hand side graphic illustrates the age profile and gender of the population. So again, we can see at a glance, you know, many of those questions, as I said, the only bit we can't answer at this point in time is how many of those people live alone. But again, we can work on that. The final area is relating to smoking and tobacco consumption, and I think our medical director Neil mentioned earlier today some work that's already taking place in terms of healthier and fairer groups. So again, this will link to some of those conversations. But what's the relevance of smoking in each of our current 13, soon to be 14 places? How many people attend smoking cessation services, and what are the quit rates? So we can see that almost 15% of people 16 plus are smokers. That's a high number. We do have a target by 2030 to reduce that down to 5%. Again, we can see from our place-based data the prevalence across our entire footprint. And although we are aware that some of that cessation opportunity has stalled during the pandemic, we understand now that data and processes are picking up to address those activities. And treating tobacco dependency, there is a task force that will be using some of that data to improve those conditions. A lot of data looking at the quit rates, and again, as a headline, it appears that the quit rates have reduced almost by 50%, perhaps as a consequence of the recent pandemic. We do know by location that certainly at this point in time, Hartlepool doesn't have a stop smoking service, so that might be an area for further focus. And we've seen some of the impact over in North Cumbria following the pandemic and some decline there. So there has to be some further improvement, actionable insight into those services. In terms of the quitters, again, a significant decline, perhaps attributable to the pandemic, but we have data that takes down to place level so we can get a greater understanding of areas of focus and improvement as we move forward. So, Chairman, I'm happy to take any questions at that point, if that would be appropriate. Thank you.
Well, thank you. It's a very interesting presentation, Graham. Thank you very much for all the work that went into that. So we throw it open now to questions and comment. Eileen.
So first off, Graham, let me say that was a great, really, really great presentation, and I couldn't welcome this enough. You know, it's a good place that we've got to. I've got a couple of points, and the first one is the issue of trust, and I love the quote. I think we need to do a job of work to ensure our public is well informed about the opportunities and benefits of having data-driven prevention, health and care before we just assume that, you know, well, we must assume people have the right to opt out. But what happens is people, you know, read all sorts of stuff in the media and they're not really given the opportunity to understand how good, appropriate use of data can drive more targeted, efficient and effective care that will help them. So I think that's a real kind of challenge for us to do as we bring this on board. And on your cycle of, you know, data in context to action, I think there's a bit that we need to think about after action, and that is how do we capture what impact those actions have, because things change in the world because of our complicated environment, politics, etc. So when you just look at some of the snapshots of prevalence, we know that figures go up and down for all sorts of reasons. So we have to think about how do we capture the change that we make if we take actionable steps. That is down to what we've done, so that we can actually share, spread and learn from that properly, rather than just having snapshots about where we are in a system, but also know that some of the changes that we see might be to do with, you know, staff going sick or governments bringing in a policy. And so I couldn't stress enough what you know I'm going to say about not just having data experts and topic experts, but having experts in methods around quasi-experiments and natural experiments, so that we can actually evaluate properly and actually use the sort of the data in context, drive action, and then use action to learn what's been good, what's not been good, and how we can sort of cycle forward.
So Eileen, if I could just respond to that, Chairman.
We take a couple of comments at a time, and then you can respond. Rajesh.
Thanks, Graham. I think it was excellent. And I also like, Chair, your approach to stimulate the discussion to have those 10 questions. I was just wondering whether the previous discussion on strategy, and maybe those 10 questions might be part of that, but whether we could also reflect on seeing which could be the 10, 15 or 5 questions which really are relevant to that strategy. Okay, so that was the first one. And the second question I had was, I know it's very early, and it's maybe a question for yourself, Neil, and even the provider collaboratives. Could we progress this further as we understand and get more insight into a clinical digital strategy, which looks at prevention, empowerment, self-management, or maybe even monitoring and care for specific conditions? Because, you know, I mean, lots of us do that in kind of, you know, ways in our local areas and provider organizations. But it would be really a great advantage if you've got all that information which drives that forward.
You want to respond to those 2 questions here?
Yes, thank you, Chairman. So I'll just answer Eileen's question to start with. So I completely agree, Eileen. We need to bring patients and the public along with us. We do have a lot of point engagements, and what we want to try and do is work with Claire and her team to make sure that we bring this into the broader public engagement strategy. So Claire's and her team are well and truly involved in this. The recent secure data environment, we're already starting to mobilise some opportunities there. Linked to your question about how do we then improve and feedback, this is absolutely linked to becoming a learning health and care system. As an engineer and as a process engineer, the concept of closed loop control comes in. So how do we measure, you know, we can't control what we're not measuring, but how do we take learning as a measurement, feed that back into the system, and then tweak our set point to get better each time, moving towards the set point? That's the process, the way my mind is wired up. So it's exactly in line with what you said. And Rajesh, just in response to your question, we are in a health and care system. The strategy isn't about digital. It's enabling better health and care, and it has to be delivered through all of our practitioners, be it clinical or local authority care practitioners or whatever. This is an enablement to go from good to better.
Thank you. Tom.
Thank you. Thanks, Graham. I think it blows my mind in the world that we live in that we don't have more personalised control over data within the NHS. And I think we saw some really good examples of how that could be done during the pandemic when, you know, needs drove kind of innovation. I'm just wondering how much that kind of self-control of data plays into the data strategy and how much we could potentially harness that to help people have greater control over their own health and well-being. I appreciate that in itself has the potential to widen inequalities, but actually it helps us to generate more self-driven self-care while then protecting some resources to target those that need it the most who don't have the same level of digital skill.
Thanks, Tom, and that's a great point. So I mentioned during one of my slides about becoming more self-sufficient. The same principle applies to our citizens and patients. Ultimately, you know, citizens rather than patients, and that's about prevention. We have seen, certainly through the pandemic, the use and adoption of technology, but conscious that not everybody can or will. So there is a link between health inequality and digital poverty that we need to address. One of the aspects, again, through learning lessons from elsewhere, how do people opt out? You know, because not everybody wants to do this, so we need to give people a choice of preferences. So some of the work that we're doing now in respect to patient engagement and a platform to allow patients to be in more control will be their choice of preference. Do you want to contribute to research? Yes or no? If you look at what other industries have done, banking, travel, leisure, they've put the citizen as an extension of their supply chain. And we need to do exactly the same thing. Back to Eileen's point around how do we get people to trust what we're doing, let them understand the benefit of what we're trying to do. It's about communication and education, but then giving citizens the choice.
Quite a few people wanting to come in now, which is very good, but we'll do them in pairs just so that you... so David Stout.
Yeah. Graham, are you able to say where we sit in this part of the world compared to other ICSs of the part of the country? Are we below average, require improvement, or par for the course, or actually not too bad? Where would you describe our starting point?
Yeah, hold that thought.
Jacqueline. Then it was John next, John Rush.
Yeah, just you started off part of this as well, Liam, by saying I'm sure you'll have other questions yourselves in terms of the data you'd like to see. So as we talk about partnership and as we talk about the different players within that, the point from me is that this is a real opportunity to take our partners with us and send a clear message that we are in this together. I know our first obvious partner is local authority, social care, all that sort of stuff, but I'm kind of thinking a bit wider than that. So you don't have to look very far in terms of things that were mentioned already today about domestic violence, about drug abuse, about crime, about young people involved in crime. All those things, they all link together. And I don't think we've ever really cracked some of that in terms of what we see. Yeah. Now, initially, you'll kind of go, oh, is that a health issue? Well, the answer is yes, it is. Because and again, it widens as well. I know we've touched on before about housing and deprivation and the type of housing. I just think this is something that actually, as an ICB, we could take forward and involve different organisations and different communities and really kind of make something happen. So I welcome what you've done because it's really stimulating. So thank you.
Thank you, John. So if we can maybe answer David's question first. So in terms of our ranking as a system for digital and data maturity, I think we're probably in the championship. We're not quite Premier League yet, but we are getting there. But compared to others, I think we're in a strong place. Our broader system, our provider landscape, we've got a number of organisations, including Sunderland and South Tyneside, who I would say are on an international level of maturity. The health information management system is a barometer of international maturity. Sunderland and South Tyneside are in the Premier League. We've got a number that are certainly in the Championship, but we've also got one or two that are in the Whitby and District Sunday League. So that's the comment about levelling up and that maturity. As a system, we do need to do a formal assessment, and I would imagine that process will take place. We're only just 8 months old, so we've still got a way to go. But what we have done is taken our assets and our services and take a good idea and make them better. That would be the principle that I would use here. Just picking up John's comment, the infrastructure that we've designed will allow data from every source to be populated with appropriate controls and governance. So if we need to bring in criminal justice type data or fire brigade type data or anything else, we have the capability, but we need to make sure to get the controls and governance right. Most importantly, public trust in what we're doing and why we're doing it and what the purpose would be.
Okay, Sam, do you want to come in now or wait till the end?
Yeah, I'll come in, Liam. I just thought it was a great presentation, Graham, and I would certainly endorse your assessment of where we are as a system based on my experience also of working elsewhere. And currently I'm co-chairing the digital and data work stream as part of the Hewitt review, and I think the fact that digital and data is one of the 5 work streams in that review demonstrates the importance of it. So I think it's really helpful with considering this here. I think in that context, I was really pleased you ended on that slide. And I think the point you made, Eileen, is absolutely crucial, which is our relationship with the public, particularly in relation to their data and how we utilise it. I think we've got an opportunity, and perhaps we need to think about taking this presentation with some recommendations through to the Integrated Care Partnership, because I do think a more civic-wide data sharing agreement would provide us with that opportunity to really, really address those inequalities. So it's good that we've got this early work on one of our key enablers in our integrated care strategy. We can't do it on our own in health. We absolutely need to see where we can join up the data. And the frailty area, how many people live alone, our councils would know that. Yeah. And so, and if we think about the work also that we've launched around energy supply and actually encouraging people to register for the vulnerable priority list, I think if we can articulate through that intelligent client council why we need this data, what purpose it would be used for, I believe that would give the public far more confidence, and we could use a consultative process with our communities and public where we are looking to join up the data in that way. So it's probably a very long-winded way, Chair, of saying I think this will be a really critical item for our integrated care partnership. We should, I think, certainly endorsing the points John made, take it there for consideration also.
Okay, take another couple of comments. David Thompson and then Mike Smith. David.
Thank you. Thank you. It was very assuring to see on the list of...
Can't quite hear very well, David.
Right, thank you. It was very assuring to see on the list of features for high-performing trusts that one of them was active participation of patients. And it is also assuring to hear the messages already conveyed to the meeting about the participation, the experience of patients, whether it be lived experience, citizens panels, engaging with seldom heard groups, focus groups, or whatever. And just to reinforce from Healthwatch the importance of engaging with the widest possible community to provide a meaningful, direct, personal insight into all the data and information statistics which you already have. So just reinforcing that message, and thank you for having confirmed that already.
Thank you. If I could just respond, David, Healthwatch are a really significant member of our secure data environment programme as well, yes, so there's a voice there. Thank you.
Thank you.
Thank you. Mike, this is a particular interest of yours, so I'm glad you're making a comment.
It is a passion of mine, and I thought that presentation was excellent, and particularly at a high level view. Even at that high level view, identifying that Hartlepool, an area with significant deprivation challenges, lacks a smoking cessation service, was something that I feel should have been something we were aware of even before now, such as the significance of it. One of the challenges we've got with such a complex system, and there's data everywhere at every single layer, is that you can look at everything or you can look at selected parts, and you highlighted that you will have to make decisions about which bits to focus on. Do we need a larger analytical workforce in order to be looking at a much broader range of indicators and to deliver those levels of insights, recognising Eileen's comments that we really need strict methodological approaches to make sure we are seeing what we think we're seeing? How large a team do we have now? Do we need to grow that team? Is this something we should be focusing investment on?
Well, we are using a workforce that exists that used to support the former CCGs. Do we need more people? I think we always need more people. The intention is to give other colleagues within the workforce the basic skills, so that can then allow the analytics experts to focus on other more problematic areas that might need further insight and intelligence. But in addition, and again, as late as last week, we were looking at some tools that will support analysts, machine learning, artificial intelligence. So that supplements the skills base that we've currently got to provide some degree of automation and decision support. So it's not just about people, although people are, fundamental to this. We need to generally upskill the workforce, including those analytics experts, but complement that with technology where that's necessary and appropriate as well.
Thank you, Graham. We've got about 5 minutes left, and more comments coming, I think. Claire, you're next, I think.
Thanks, Chair. It's just to provide some further assurance. So Graham and I have met quite recently with the data and digital team, and there's a huge amount of work from a public and patient point of view, David, and it's great that Healthwatch are involved in that. There's some broader work to do with stakeholders too, because we have to make sure we inform and engage with the public and patients, but also make sure we build confidence with our stakeholders, and that will be a priority over the next 6 months.
Yeah, thank you. David Chandler.
Yeah, thank you, Chair. And Graham, thank you for an excellent presentation. And I think you shared with me that some of the benefits of an ICB and the benefits of working at a scale that maybe we didn't have in the previous setup. So thanks for that. I was just going to mention you on the Whitby and District League. I'm sure they're pushing for promotion. You mentioned a Vanguard proposition, or the Vanguard, and a few of us will remember that. So I'd love to help you and work with you on our value proposition around that, because I think there's a real opportunity there based on some of the work you're doing there. So that offer is there. Absolutely delighted to work with you on that one. I'm sure other colleagues would as well. I was going to ask you about two things. One was about data quality, how you think that is. And the second one was maybe you could just share us a little bit more about the benefits about AI. Because I'm just wondering, is that something we also need to explore going forward?
Okay, thank you.
So a quick one, Graham, because we just need to get through a couple more people and then we can conclude on time with this item. Go ahead.
Okay, so thank you, David, for the offer of help. I'm already doing some work on the broader digital agenda using a model that finance colleagues developed many years ago, the Informatic Skills Development Network. This is a bit more focused. In terms of data quality, in one of the graphics I illustrated, there's a data quality layer. So we will learn how to, ideally get it right first time, but where we find that there's repetitive data quality issues, we need to close the loop and improve that quality of data from source. If we just correct it after source, it doesn't solve the problem. So that's an area I would mention. And was there a further question?
It was just about AI. But I mean, it's probably a bigger conversation for another time. But
yeah, we do need an AI strategy. We've got lots of AI things going on, but we need to coordinate it. It's not the panacea for every challenge, but it does have its use cases. More work to do on that.
Joe.
Just a quick one. I had a lot to say, but a great presentation, as everyone has said. Are we linking in with the National Innovation Centre for Data?
We are linked to a number of national bodies, Joe. That one, I'm not sure, but I will find out.
It's just by the university. It's really good. Really good.
Thank you.
Neil.
I remember the work of NEQOS, and NEQOS are still around, and they did quite a lot of this work and providing answers to those specific questions. They combine data analysis with epidemiological expertise, and I think they're an organisation that we could look to use more. And then my second point and final point is, not to put a dampener on things, but again, to give public reassurance and reassurance to the board that the Caldecott 8 principles of data sharing and use, we do obviously consider those, and we'll need to just make sure that they are woven into the work that Graham is describing.
Well, that's been a great discussion, a great presentation. Thank you for the work, Graham. I'd just like to add, by way of conclusion, I feel very optimistic about where we're going with all of this, but my three kind of end points, which, as I said in the past, I've never really seen, is the insight, the data information provided, which we're getting to now. The other one, which is very rare in my experience in healthcare, is curiosity. And I can remember when I was doing some work on patient safety, when we produced a report in the year 2000, an organisation with a memory, going to visit the air safety people and walking past a room where people were chattering in loud voices. And I said to the person that was showing me round, what are they doing? He said, they're so excited about some of the incidents that they've heard over the last 24 hours, and they're working out ways how to solve them. That sort of curiosity is lacking often in health. And then finally, action. That if you see something, what are you going to do about it? It's almost that the data is asking you that question. You know, I sometimes think that. I look at some glaring thing where people here are dying 5 times more from cancer than they need to be. It's almost as if the data is accusing you. What are you going to do about it? And I think that's the other thing. So insights, curiosity, and action would be my 3 markers for whether we're the best of the best or we're in the Whitby League or whatever it is. Okay, thank you very much. We move on to our second deep dive, which is David Perdue is going to talk to us about discharge.
Thank you, Liam. So we're starting off actually with the care conundrum. So acute hospital care for older patients saves lives. Planned care for older patients helps them to remain independent. Staying in hospital after they're medically fit is hazardous for many older patients. And large numbers of patients stay in hospital longer than appropriate because meeting their health and social care needs in the community is not possible. So this is some work done by NEQOS, which looked at the adverse effects of prolonged hospitalisation. So in terms of the work they did, and lots of research is done about deconditioning, so pre-admission levels of independence is quickly lost. So in the information they looked at, and they reviewed over 700 patients, those with 3 or more nights delay, 1 in 10 will suffer actual harm. So that was mainly around falling in hospital, hospital-acquired pressure ulcers, or some kind of infection due to being in hospital longer than they needed to be. So with the delay of 5 or more nights, 1 in 5 will deteriorate so badly they can't be discharged, or they can't be discharged to their home or where they should be going, so their levels of care are increased the longer you stay in hospital. And then by 28 days, 1 in 3 will suffer harm. So that was a linear look at, actually, day 3, you had a 1% rise every day in your risk of harm whilst you stayed in hospital. So this work is some work we're doing across safety, across the whole system. So we're also expanding this to actually, if we have people delayed in hospital longer, then that affects flow through the hospital. So actually, what is the harm caused by being at home waiting for an ambulance and overcrowding in an emergency department? Or actually, if we discharge people to the wrong place. So actually, if you put somebody in a residential home when they should be at home, then they will continue to decondition. And there's evidence to show that actually by doing that, the people will remain in residential care rather than going to their own home. So what's the state of discharge care in the ICS, and how does it compare with other places? So we're classing this as the awful term of patients who do not meet the criteria to reside. So yesterday, our system had just under 9% of our beds occupied by people who don't meet the criteria to reside. Now, there's a large variation in that, ranging from systems, so from 25%, and that yesterday was 26%, and our lowest was actually 2.8% yesterday. Now, with all of our systems, the majority are under 6%, and there are 3 that are over that. Where we compare to our other regional ICBs, so the best in the rest of the patch is currently 14.6%, going up to 18.9%. So we have a very strong performance in terms of people not meeting the criteria to reside. So when we've looked at all of these, and these are my kind of review of all the data, talking to people, looking at actually what we need to do, these are our factors in safe, effective discharge. So recognition that home is best for the majority of older people leaving hospital. Care must be tailored to meet the needs of the individual and not arranged for organisational convenience. So there's lots of work looking at strength-based assessment and approaches. So treat a person with what they've got, which is a positive, rather than treating a person as what is negative. And that includes their social environment in terms of who cares for them and what support mechanisms they've got in place. So we need to use all the funding options must be available. So looking at personal health budgets, integrated personal budgets, or via commissioned services. We have a constant focus on maximising independence for all post-discharge recovery and support services. We have a positive collaborative system leadership with clear vision, trusted by partners and a determination to solve problems and blur boundaries as necessary. And we'll talk a bit around that one because actually that's the approach we have taken with the discharge funding that we've had. So performance metrics must be based on outcomes for service users, not individual organisation indicators. And preparation for discharge begins at the point of admission. And then good post-discharge care can only be provided by flexible, multidisciplinary, multi-agency working. So we look at, there's a slide missing for some reason. Sorry. So we look at data, but actually we need to know what people are saying about their process and what happened. So these is a mixture of people's inpatient picker surveys in terms of the questions around discharge and some work that we're having working with Health Watch. So what must be stopped doing is allowing people to get lost in the overall pressure of day-to-day operations. Move people to other wards, hospitals or care homes without discussion with individual families or carers, and then keeping people in hospital when they want to and could go home. So part of this work was looked at the paternalistic nature still of acute provision, and actually clinician knows best. That's not always the case at all. And we've seen that in a lot of work that we've done in terms of over-prescription of care requirements for people when they go home. So what should we do is ensure that we provide clear information at all stages of the inpatient stay. Follow the basics of good discharge. People go home to their own property with medications at a reasonable time of day. So I've been looking at discharge for the past 12 years as an acute provider, and that comes up every single time. We don't seem to be able to get take-home medications on time, and we still discharge people after 10 o'clock at night. Make sure planned discharges take place unless the person becomes unwell. Ensure transfers of care to other providers are accompanied by accurate and up-to-date information relevant to the person being transferred. Improve the understanding of discharge to assess across our staff and our communities. Provide every person who is discharged as a named professional who knows about the person's medical care plan and can discuss this with the individuals and families. And then finally, foster a learning environment that is open to feedback and tackles issues. So we can look at all the data we want, but actually the people involved in this process know better than we do. So just in terms of discharge and the national context, COVID-19 brought a massive change to discharge from hospital and how we were enforced to do that. So there's a massive focus on freeing up hospital beds. So discharge to assess in place at pace was fully funded. And there were set timescales for discharge. So when it first came out, actually, if you were fit for discharge, you were going by 12 o'clock that day. Reiterated the need for 7-day working, clear setup of action cards. So we still have those action cards which tells every single person what they should do in terms of discharge. And we suspended CHC assessments, so that's continuing healthcare assessments. In August that same year, that became the fully hospital policy. A further update to include reference to community designated settings, funded changes, and increased focus on carers. And we are still waiting the latest discharge policy, which was due kind of in the middle of the summer. It's still yet to be launched. But actually, in terms of some of the changes and what it tells us, is there's still now no requirement to discharge to assess, but it is seen as best practice. So focus on home-based, strength-based approaches, and the need to consider carers. And then in terms of transfer of care hubs, people should not routinely be moved out of hospital to free up beds. However, there is no right to remain in hospital if care is no longer required. So there's a an escalation process for that, which there's 3 letters that are given to patients as they arrive, if we follow the patient process properly, which tells them and clearly states that actually if you stay in hospital, if you're fit, you should be leaving hospital. But we have to offer choice to wait in alternative settings if choice of provider or care at home is not available. So this is a really difficult one that I think people on the group kind of in trust really struggle with, because actually going to a place which is going to be your long-term residence, it's like moving home, isn't it? What we don't want to do is put somebody in a temporary accommodation to move them somewhere else, but actually that is the process that we should be following. But very difficult, and some of those conversations are hard and don't always take place when they should take place. So in terms of funding, there's no national funding, it's the local areas to agree, and there's suggestions of pooled resources with social care through Section 75 or use of the Better Care Fund. And we're clear how those funding changes duties will be met in discharge to assess. And then in terms of Care Act, we have to always have consideration should be given to the Care Act duties, particularly in sections 2 and 3, which are around prevention and care as an integration. And in terms of other things, there's non-explicit reference to joint commissioning strategy or balance of independence and risk, but all areas need to have an exec lead, a system coordinator and transfers of care hubs. And the mental health services were excluded from the first part of this, but encouraged to adopt the same principles. So actually, in terms of understanding the discharge pathways, in terms of if you don't meet the criteria to reside, there's 4 pathways. So pathway 0 is the person's able to return home with no support at all. And that should be 50% of the discharge for people over 60. And the ward staff and the obviously clinician makes that decision in terms of those people going home. So one of the things we're looking at in terms of pathway 0 is the time of those people going home. So actually we'll free up far more beds if we discharge people by 12 o'clock midday. The data's telling us we still discharge people, majority after 12 midday and more than likely after 5 o'clock at night. Pathway 1 is the need for support to return home. That's 45% of discharges for people over 65. And again, that's ward-based staff with support from transfer of care hubs. So that's people who need a care package of some description at home. Pathway 2 is further rehabilitation in a bedded setting. And that's 4% of discharges for people over 65. And then that's the therapists and transfer of care hub lead professionals make that decision. And then pathway 3 is a new placement into a nursing or residential care home. And that should be 1% of discharges for people over 65. And that's a transfer of care hub. Must clarify why a pathway 1 or pathway 2 is not an option. So we shouldn't be discharging people directly into long-term residential or nursing care. And it's where that assessment takes place. So one of the biggest things around discharge is not to admit patients in the first place and to look at admission avoidance. So there's community-based health and social care, so that's the integrated care hubs. There's a 2-hour emergency response system, and then adult social care and short and long-term services. So from our ambulance providers, more impact on see and treat, so don't convey to hospital, and look at alternative approaches and pathways in terms of a director of services which offers a different view to going straight to hospital. And from a primary care perspective, timely support for citizens and enhanced support for care homes. And in terms of our turnaround services, there's same-day emergency care centres and home first teams. So that's teams that are multi-professional, so social workers, therapists, nurses working into emergency departments to turn people around rather than admit them. Because once you're admitted, we'll do every test known to man, and you will stay in hospital far longer than you need to. So part of the government made special funding allocation of £500 million to systems, and our share of that was just over nearly £27 million. And that money went through the Better Care Fund. And what we did, we looked at the primacy of place. So the funding, so some funding came straight to social care, to go through the Better Care Fund. Other money came through the ICB. And how we looked at that money, we used the same approach as the social care allocation. So we've got 15% of the population in the patch, we've got 16% worth of funding. And part of that was kind of our deprivation levels, which allowed us to have that additional money. But we gave that, designated all that to place, and the place directors working with the local authorities, voluntary sectors and the acute trusts to decide how that money was best spent. So it had to go through the Better Care framework under Section 75, and the Better Care framework in essence was set up to enable the right care in the right place and at the right time. So the implementation of the Better Care Fund was to introduce capacity and demand planning for intermediate care to help winter system preparation, and the over £500 million for ICSs. So that money, we looked at actually what was the need. We could just delegate it to to health and wellbeing boards, but actually we had an assurance process that came back through the ICB to look at actually what was being spent, was it being spent in the right places that would support people to get to where they needed to be. And we had to put the final return back on the 16th of December. So if that return was late, so we had half the money at that point, if the return was late or we didn't fulfil what we should be fulfilling, there was a risk we wouldn't get the second part of the money. But it all went in on time. So just in terms of the breakdown, that's where the money was across 13 places. And in terms of how it was used, these are the scheme types in terms of how we looked at that funding. So there's a mixture of residential place settings, additional capacity for current care workers in place, assisted technology, bed-based alternative intermediate care, home care and domiciliary care, improve retention of existing workforce, increase hours by the existing workforce, local recruitment incentives, and then other voluntary services support, and reablement in people's own home. So that was the split of money and how it was set out. And the next two slides just show kind of where that is in the individual places. This needs updating, I'll update it to make it all to 100%. We then had further monies come through. So there was a share of 200 million came through, which our ICB got 11.4 million. And that was very specific, and its use of that was for 4 weeks paid care, either in a bed base, and then when we pushed back to say actually bed base doesn't help, it then was 4 weeks of a package of care. So that money ends at the kind of end of March, but actually in reality at the beginning of March. But what we had with that money, that's a very different process, so that has come to the ICB and it's a drawdown if you use that money. But as you see from what we've done before, we'd actually invested a lot of the other monies in those two pathways. So we're now looking at actually how we can utilise this money more effectively across the system. So in terms of the monitoring and metrics are being introduced, so this is the metrics for the first 500 million split. So it's looking at the number of people discharged into their usual place of residence, the absolute number of people not meeting the criteria to reside and who have not been discharged, number of bed days lost to delayed discharge by trust, the proportion of bed base in each trust occupied by patients not meeting the criteria to reside, and then the number of care packages purchased for care homes, domiciliary care and intermediate care. So we do that return every fortnight, the last one being yesterday, which assures we get the funding for the next stage. The extra 200 million split, 11.4, is a daily template with 43 lines of data required to get the money. So I've seen lots of templates in my time. This has to be one of the most complex templates I've ever seen, and not very easy to fill in. But it is being done. with support of NEXT. I think it's really important what we share, what we've learned as a system. So part of the discharge process was 10 high impact interventions for discharge. So we looked at those where every organisation had self-assessed, and then have done some peer reviews of those and looked at the learning across the different systems. We have daily director of place meetings at 4 o'clock every day, chaired by me, which actually have been really helpful and useful for the system to look at actually where the key issues are, and actually early heads up of issues. So that might be early heads up of actually cares becoming a problem in a certain patch, and then what can we do about that? So actually, what have we done in terms of enhancements, incentives for carers to work in that particular area? But we've actually shared good practice. So some of the highest performers in this area have actually looked at what we can move across and what can easily be implemented in different places. We have really good multi-agency working. It's worked really well. And actually when issues have been raised, we've looked at them and what we can do different. So one of the key ones for this is actually when is a person not meeting the criteria to reside. So actually just because a consultant's done a ward round or they've done additional ward rounds on a Friday morning and we have 37 people added to the list, actually those 37 people weren't all ready to be discharged. So actually there was a lot of to-ing and fro-ing, and people actually weren't medically fit on the list, and actually our social care colleagues were taking lots of time validating a list instead of actually doing the work. So actually we took an action from that and looked at a SOP to actually how we work together to get the right one version of the truth. And actually come out of this is actually some other pathways that we need to do some work on as a system. So one of those is around rehabilitation, and actually what is our rehabilitation offer as an ICB, especially for specialist rehabilitation, and what we need to do differently. We've got a task and finish group taking on that piece of work, and we've also looked at repatriation. And actually, what does repatriation really mean? It's just because somebody might have a Sunderland postcode, but actually they live closer to Gateshead and end up in Gateshead. Well, actually, are they repatriation? No, they're not. But actually, we need to look at the systems and actually have some trusted assessment that actually you don't have to travel as a social worker from Sunderland to Gateshead. We have a shared vision of what that assessment is, and we trust it. And then obviously we've had feedback from people's experience and learning. So with all of this, we'll have some negatives that people feel that they've been discharged too early in the process. And we've gone through those and reviewed them and are doing some learning from those. But I have to thank all the key players in this, the directors of place for their leadership and the local authorities and the voluntary sector for the work that they've all put in to make this as successful as it has been. So when we started the process, we had 11% of our beds occupied. We're down to 9. At our best point, we're at 8.2. But actually, it's quite interesting when you look at all the data. So actually, our lowest percentage was the week after Christmas, when we have the joyful reduction of people wanting to go home. When you looked at our other regional colleagues, they were sitting at kind of mid-teens to high teens. Theirs went down to less than 5%. Actually, ours only went down to 6.6%. So actually, it shows that actually the system runs well, that there isn't a massive variation. One of the key things is around mental health. So we did a 100-day challenge for acute providers in the summer. At the moment, our 2 mental health organisations are going through the 100-day challenge. And these are the 10 high-impact interventions that are now being focused on mental health provision. Our 2 mental health providers have got a very different data and information in terms of people who are delayed. One at the top of the, as in worst performer, one who's the best performer. But that needs to look at individual processes and how they're being done. And in terms of the funding, £1.3 million of that funding was dedicated to mental health and mental health provision. So looking at all the information and what we've got 4 key strategies going forward in terms of our strategic plan for discharge. One is to improve the data accuracy. We'll have a short clip from Optica. But actually that's really important. So that single version of the truth in terms of data, but also actually data coming out of the acute providers in terms of the actual delays, but actually what the bed numbers are. So actually we've got some really interesting daily returns to the Department of Health that shows some of our organisations have got less beds than they should have, and some have got more beds than they should have, which obviously so there's some work, and the individual organisations where that applies to are being supported through that process. There's a key bit on 7-day working and how we do 7-day working across all of our systems, and that's in health and social care, especially in terms of community response. Escalation, in terms of we've had escalation meetings at weekends at the worst point of this. When we asked social care to join that, they did, but actually it wasn't helpful because we didn't have the right metrics and looking at that. So there's some work we're doing around OPAL levels in terms of health and social care, so we have an understanding of where we are. And then the biggest issue for us is workforce. In terms of our one workforce, how do we get people into the care setting? And currently we pay the lowest wages to people looking after some of our most complex patients. So we've got a strategic piece of work around workforce planning that Steph Downey leads as the DAS for workforce, who works really close with me and Annie's team to look at actually what are we going to do across the system. And then from a learning aspect, we've got a meeting that Annie and Ajaz are working with me to look at a learning event from discharge on the 9th of March. So there are now 2 quick films. First one is around Optica.
Don't want you to know about this affordable, more advanced alternative.
hospital or whether they don't, and then we'll update that on the EPR system. What then that happens is that pulls that information of those patients into this very succinct list of patients that we know we're trying to progress the discharge. What then happens is that for each of those patients we can break down exactly the tasks that we're doing for discharge. Discharges can be very complicated, some are very simple, but some involve multiple agencies, multiple steps. So what we can actually do is track those steps in real time and look at who's responsible for the next step. So what it does is it stops the drift of time between those steps and allows us to really understand who's responsible for it, where we are with it. I think prior to having Optica, we tried to monitor this through the Excel spreadsheets, but we've been more measuring in days. Now we can measure the tasks in hours, which is clearly going to reduce that length of stay. It allows me as head of patient flow to look at where the bottlenecks are and actually look at where we need to escalate to actually get that patient moved through. It gives us that visibility in one place of everything that we need to do for a patient's discharged.
So Liam left us with a challenge as to how we transform support and care for frail older patients leaving hospital.
David, thank you. It's a very, very complex problem and he unravelled it beautifully for us, so thank you very much indeed. We are now quite tight for time, the ambitious timescale of this agenda, but so if I could ask you to make your questions and comments brief, and we'll bring them all together, David, and if you could make a note and answer them as you go along. So Tom was first, I think.
Yeah, thanks, David. There is a nice guideline on this very topic around transition between inpatient hospital settings and the community, and an associated quality standard as well. Yeah. One of the key elements is around information on admission as well. So obviously you've touched on how people are tracked through, and obviously relationships are key to that information sharing. What about at the very front end, when actually that guides what the hospital stay looks like, and you can start planning for discharge from day zero, really?
Eileen.
Thanks, David. That was a really spectacular presentation. My point is really about some other nice guidance that I was part of the development of, which was about excess winter deaths and cold homes, NG6, I think it was. It was developed in 2015, and that was way before a cost of living crisis. I mean, one of the issues that can be a blocker is the idea of people going home to poorly heated homes. We live in a northern climate. We've got poor housing stock, and many people are economically deprived. And I guess it's a challenge for us as a system. What can we do about that? Are we able to prescribe support for energy bills, etc.? Because for staff and for people and for families, particularly with older residents who are sometimes reticent to put the heating on, we know that going home to a cold home can actually exacerbate their underlying health conditions.
Thank you. Anne. Anne.
Sorry, Liam. Sorry, thank you. There's probably loads that I would say on discharge, but first of all, to say how proud I am of the staff who did that video. They were very nervous. I think one of them, Emma, was actually a PA support to me in 2008. So to see her in the role that she's in is fantastic. I won't repeat some of the things that have come through in the presentation, but certainly just to remind board that these discharge teams are very small. So they're very small groups of staff. The model within North Tees using Optica is superb in terms of having one version of the truth. So the data that Graham spoke about earlier on, just that we don't argue over who's on whose list. And I think the criteria to reside medically optimised as a social worker, I'm uncomfortable with it. Safe and planned for me is about getting people very safely back to their home, their bed, or wherever the best place is. So lots of work. I think we've been involved in lots of daily ICS surge calls, regional calls and national calls in terms of discharge, and certainly we've got a lot to be proud of, and certainly coming through Christmas and New Year and hearing the sharing of information, the sharing of support has been second to none. Still got a long way to go, lots of challenges, workforce in particular, as David's already covered, but I think we've got a lot to be proud of. Thank you.
Okay, David, you want to respond so far, and then we've got other comments coming. Yeah.
So in terms of front end, Tom, I suppose that's one of the principles we said at the start, is actually discharge starts on admission. So that is really important that people are bringing the right information into hospital. But we'll pick that up as kind of one of the task force we look at, especially for the mental health patients. And just in terms of people going to their own home, this is an interesting one in terms of kind of heating, and if there's heating there, is actually how we encourage people to use it. So we do flag to kind of voluntary sector, citizens advice, and all the different support that people can get when they go home, so they are safe in their own home. But it's quite interesting in terms of some of our paternalistic nature in terms of what is the right home and home environment, especially people who like to hoard. Actually, they've lived in that environment for years, and actually we just need to ensure that actually the people are safe when they go back.
Okay, we can't run over time because we've got the guest speaker, so I'll ask you to be, you don't have to put your flags down, but just be brief. Ages.
Can you hear me? Great. Very quickly, joining the dots with the previous presentation and question that David Chandler asked earlier, I think I'm really interested in specifically the avoidance, admissions avoidance, and I think a role that good data could, combine data as well as there's some very interesting opportunities around the use of predictive analytics and artificial intelligence there that we could apply to as our data capabilities grow to increase some interventions that can help target people who are likely to end up in hospital early enough. So some opportunities to explore there.
Thank you. David Thompson.
Thank you. I think the whole presentation reinforces the need for appropriate information to be brought to the Integrated Care Board on social care. I appreciate it is not easy because the ICB doesn't have any direct responsibility for social care, and care homes tend to be independent, but to bring information to help with the insight and therefore the action to this board and to place boards would be very, very useful, not least because it would be true integration.
Thank you, David. John.
Just talking about people and partnerships, if anybody wants a crash course in how to work in partnership at an integrated level, I suggest they get involved in this process, because you see demonstrated both fantastic behaviours and some very toxic behaviours of passing buttons and blaming and everything. So the only thing I was just probably wanted to say is that this is where I use the phrase organisational empathy, understanding how each of the organisation, their roles and responsibilities is a key part of this. But it's one that I think we're working our way through, and I commend anybody who's having to work in those environments, because I don't think we appreciate the upset, the concern, and sometimes the joy that they felt there. So, yeah, if you want to do it both strategically and operationally, go and do something in this, because this is real hard work.
Thank you, John. Annie?
My point is linked to a number of those, and thanks for the presentation, David. I noticed how the mood in the room changed when we had a chance to watch the films and actually listen to Phil. And it made me think of, do we know enough about how many Phils there are out there across the system? Because my bet is if Phil was looking after my mum or dad, he would be doing it in a very special way. So it's about elevating our ambition. I wonder about how we systematically capture workforce experience, understand the social work experience in the process of, and community teams experience, bringing people out of hospital, informal carers, and their contribution to our workforce across the patch. How much do we really know about that experience and our opportunity to integrate it with the quality of patient experience against the key actions that are defined in our strategy. So I think we have an opportunity to really stretch our ambition in terms of what we measure to give us the insight. I guess people like Phil will inspire us to action. So thanks for the presentation.
Sam?
Thank you, Chair. Three quick points for me. I was really struck looking at the pie chart and also how people have used the money, and I was drawn to the areas, and particularly Sunderland, on assistive technology and also Northumberland. So I'm really curious through the learning forum that we're doing as part of our learning and health system approach, what the learning is from that. And it links to the point Eileen made earlier around the sort of evaluating the impact of it. Carers, I know they're on your agenda as well, David, and I was minded throughout the whole presentation thinking about it from the carers' perspective as well, and I think that's probably an area it would be good for us to look at again at some point in the future. And then just finally on digital, and it's a bit of a golden thread today, unwittingly, the presentation we had as a board from Mark Britnell on the sort of the 10 essential aspects of high-performing integrated care systems. One of them was around standardising guidelines and operating procedures. So the things like repatriation, discharge policies, whatever hospital you go into in our system, we should be working to a standard set of procedures. And then also our sort of digital operating model. So Optica, it's a tried, proven, tested technology. We've now got all but one of our NHS trusts signed up to implementing that over the next period. And I was sort of going to go away with renewed effort to get the final trust in, because I do think part of this is about how we make things simpler for patients, for families and carers, but also staff who we know our workforce is very transient in some places, and we can save ourselves a lot of time if we're working to more standardised sets of procedures. And can it be good to pick that up with you through the Provider Collaborative?
Okay, these have to be the last three interventions. So David, Stout, Graham and Jane. David.
Thank you, Liam. David, given the lessons you've learned, but the challenges that are out there, how optimistic are you that we can actually make good progress in the near future, next year?
Graham?
Thank you, Chairman. Just two very quick points. David, in terms of your variation with the two incumbent mental health trusts, a good piece of recent development is to the appointment of a CIO that'll work between the two trusts. That will instill some degree of standardisation. And to Eileen's point about keeping people warm at home, we have been involved in a national initiative in the Tees Valley to do exactly that. Well, I'll get some more information to you, Eileen. Thank you.
Jane.
Just for information on the carers agenda, NHS England Personalised Care Leads commissioned us to work with Northumbria University on a year-long piece of research which has just been completed around carers' experiences of discharge, and we involved 8 trusts across the 4 ICSs across northeastern Yorkshire and a significant number of carers from each of those patches. And the report is not only setting out people's experiences, and the carers' experiences are very illuminating, but also drawing together the discharge practice the best practice and also production of a toolkit around how to, which we hope will be showcased and used to try to improve practice, because we obviously found it varied in many places. Happy to bring that to you.
Thank you.
Well, thank you. A lot of very helpful comments, insights, pointers to the future. Not that many direct questions, but there was one at the end, which is how optimistic are you, David? Answer that one and then we'll move on.
So I think if we keep the trust that we've developed with the systems and the strategic pathways that we're going to focus on, then I'm really optimistic. And actually, the discharge funding, in terms of the initial funding, is due to continue. So that's a big step in terms of that focus. But I do think it is absolutely the people at place who have made this work.
Thank you, David, and thank you to you and your team for an excellent piece of work. Thank you. We've now got till 12:15 when we have a short break to let Bill Kirkup in, and we have a run of governance items to do in that 15 minutes, starting with you, Claire, on the governance handbook.
Just really quickly, Chair, people will be familiar with this document. We brought it first in July to our first board. We did share with you at the time that this will evolve as our organisation evolves, and that's exactly what it is doing. It's here in front of you for formal approval within the key points, and in the cover sheet it makes clear what the changes are to the document. Happy to answer any questions.
Any comments or questions? Jacqueline?
It's a minor point, Claire, but I thought we'd done some work on membership of the board committees, and what's contained within it doesn't quite reflect what we pull together as execs. I don't know whether that's not pulled through.
Okay, we'll pick that up, Jacqueline.
Yeah, thank you.
Subject to that being amended, can we confirm that we're happy with the changes that have been detailed within the cover sheet?
Okay, we've now got a summary slide for each of the committees, and the committee chair is going to talk briefly to that one, starting with the executive committee.
Thank you, Chair. I'll take the report as read. Just two particular points. You'll note a new addition from the Committee for the Risk Register. This is particularly in relation to the healthcare needs of asylum seekers who particularly been placed in hotel accommodation in North Cumbria. And secondly, I just want to note the strategic partnership with the North East Commissioning Support Unit that we've developed, and that will be implemented over the year ahead. And Graham has picked up already in his presentation today how we're furthering our work with them, particularly around data and data analytics.
Okay. Any questions or points on that? Thank you. We'll move on to the Quality Committee. Eileen.
Thank you, Sir Liam. So highlights from the second Quality and Safety Committee. I think the committee is still evolving. We are forming and norming at this point. I think we've got an ongoing conversation about some representation from local authority social care, because some of the risks that we have around quality and safety are inherently linked between NHS and social care. You can see some of the items that we covered in the committee, and you've got the report for the longer read. I think the key issue is that we had quite a specific focus on patient voice, and it's really heartening to say there was a lot of enthusiasm from the committee to really want to hear from patients and from carers. We need to support people and make sure they're comfortable in describing their care experiences and their outcomes of care. We need to make sure that we don't become a complaints or a grievance sort of forum, and we can't have patients and carers come whilst those sorts of processes are still ongoing. But really what I take away is there was a real eagerness in the room to learn from and then improve experiences of health and care services in the region.
Comments and questions there? Okay, then move on to the Audit Committee. David.
Fine, thank you very much, Liam. We reviewed a number of things, reviewed the Corporate Risk Register and the risk of place. Not all of the risks, but the higher level risks. We're happy with the system. Just to remind the committee, remind the board that the task of the Audit Committee is not to look at every individual risk. Risks are assigned to individual managers and to other committees. The task of the Audit Committee is to be satisfied that the system is fit for purpose and has been implemented fine. And so far, we're very happy with that. We're updated on data security. Every NHS organisation in the country has to complete a return annually, so we're no exception to that, so we agreed the process for that, and that's independently assessed by internal audit prior to submission. So we went through there. We then looked at what we just looked at a few minutes ago at the board and recommended to the board that the revisions to scheme of reservation and delegation, SFIs and financial delegation should take place, and we've just done that a few minutes ago. We then receive regular reports from David on finance, but not on the same things as the Finance Committee are updated on. We get a general overview, but also a level of debtors, creditors, level of tender waivers, and any losses that have been written off. So we look at those sorts of things, so it is slightly different. Routine report from internal audit and counter fraud. Internal audit is provided by Audit One, Internal Audit Consortium. They provide counter fraud as well. And we also heard from our newly appointed Mazars, external auditor. And it's a bit tricky this year because we've got 9 sets, we have all got 9 sets of accounts to go through. That's 8 CCGs per year, April to June, and 1 ICB, 9-month period. So normally it's just 1, we've got 9 this year, but I'm sure it'll be absolutely fine. Well, I'm hoping it'll be absolutely fine, just to correct that. But that's fine.
Any questions for David or the work of the committee? Okay, thank you. And then finally, John, finance, performance and investment.
Okay, thank you. Just in terms of what we regularly do, we obviously get the regular finance report, the regular performance report. I'm not going to go through those again because we've had really good presentations from those today, but what I wanted to do was just probably thank David and Jacqueline for the amount of time and effort we put in to try and get those reports and actually how they present them. I think particularly on the financial side, it's been particularly difficult. So I wanted to say, particularly to yourself, David, thank you for that. Obviously, as well, we've been doing things around the ICB budget and the ICS budget coming up towards the end of this year, and then planning for next year, trying to make sure, because obviously I think between ourselves as this committee and the exec committee, we're going to be responsible for that oversight for the plans going forward for next year. So we're going to have to work out how we manage to see those or keep informed about those as we go in towards the end of this financial year to plan for next year. Terms of reference you've already seen because they're on the big report that we've just done there, so we spent quite a bit of time on that, and again within there I'd like to commend the presence of Ken and Rajesh there, because we basically went from 2 meetings where they were in the second meeting, we brought them into this meeting. Now yes, that can create conflicts of interest, but they are far, far, far outweighed by the contributions and the insight that we can get from providers trying to link into that overall budget setting and that overall performance setting. So I really want to say a big thank you for those people in attendance. And then on the final point, we do have a regular kind of half-an-hour update session before every meeting, if we can. It's to give insight primarily to us as non-executives and people relatively new to the ICB as well, around things like pharmacy and prescribing and how it works, continuing healthcare we've had as a half-an-hour update session, and at this week's meeting we're going to have capital as part of that process. Everyone can come if they want to, because it's only half an hour, lasts from 9:15 till 9:45 before we start the meeting, and it's usually done by somebody, the subject expert, but also as well it's done online, so if people want to dial into that, they can do. So it's just, that's to try and keep people's knowledge up to speed. That's it. Thank you.
Thank you very much. Any questions for John? Okay, well, we have a short break now, 15 minutes, and then if I could actually be back by 12:30 for our final substantive item on maternity services. Just 1 minute now. Welcome back, everybody. We're resuming the meeting of the North East and North Cumbria Integrated Care Board on 31st of January 2023. And coming on now to item 9 on the agenda, maternity and neonatal services in East Kent and the independent investigation. And it's an absolute pleasure to welcome the person who led that independent investigation, Bill Kirkup. Bill is well known to many of us around the table. He's a true son of the North East. Started off life as an obstetrician and then, like all the best people, moved into public health. And Bill was really a very pioneering Director of Public Health in North Tyneside, doing some of the very first work on inequalities in health in the country. He then moved on and was a Regional Director of Public Health. He worked within the former Northern Regional Health Authority in charge of the development of providers, capital planning, that side of things as well. And then he worked at national level, in effect, as Deputy Chief Medical Officer for a number of years. Bill has led played a part in many important inquiries of recent years, particularly the Hillsborough inquiry, which uncovered, due to his medical diligence, a large number of preventable deaths that had not been disclosed or detected in the original inquiry. Then, of course, his review of Morecambe Bay and most recently East Kent. So a very big welcome, Bill, to the North East, where you, I know, live, but you've been spending a lot of time in other parts of the country over the last few years. And over to you for what we're looking forward to, which is your presentation. Thank you.
Thank you. Thank you very much for the introduction and the welcome. And it's a great pleasure to be here. And not only because it's a 15-minute drive down the road and not 4 hours on a train to Ashford, but I do appreciate it. I'd like to tell you a bit about the independent investigation into East Kent, a story of missed opportunities. We covered the period 2009 to 2020. I'd like to do a bit of East Kent in their own words, because I think both the families that we spoke to and the staff that we spoke to can tell the story more vividly than I can, because it happened to them. A bit about underlying themes, and then finally what I see as the action that needs to follow from the East Kent investigation. So starting with the families. This was a woman who had type 1 diabetes and was used to looking after her own diabetes. She was admitted to the ward in Margate for stabilisation during pregnancy, and didn't quite understand what the midwives were doing, and this was the response that she got back. These aren't our issues and you don't fit in our box. This was a woman who had a spinal anaesthetic for caesarean section, and the spinal anaesthetic was ineffective, but they carried on regardless. This was the grandmother of a baby whose daughter, who had just given birth, was busy almost bleeding to death in theatre and then in intensive care. And the baby was hungry, so she wanted to feed the baby, and that's what she was told. That was a woman asking about the signs of respiratory distress in her baby. That was the response from a midwife who was looking after the postnatal ward. The baby subsequently died of a respiratory infection that wasn't treated in time. That was a woman who attended reporting reduced fetal movements around about term. She was dismissed. She was sent away for a routine appointment in 2 weeks' time. When she came back, her baby had died. That was a woman who'd had 2 previous caesarean sections, high BMI, previous infection with one of the caesarean sections. All of these are significant risk factors. No discussion. She was put down for a vaginal birth after caesarean section. She had a prostin induction, which is another risk factor if you've got a scar in the uterus. And she had a ruptured uterus and a stillborn baby. I think that one speaks for itself. That was somebody who was not progressing and wanted to talk about the options. That was the report of a consultant who was in the delivery room in response to a woman who had asked why were they going to do a trial of forceps delivery rather than go straight to caesarean section. And that was the response, which you can imagine would fill her full of confidence. That was a midwife to a patient after the obstetrician had left the room, disagreeing with what the obstetrician had recommended and telling her that she was going to have something different. I'm not going to comment on that one. I think it speaks for itself. That was another midwife disagreeing with an obstetric recommendation, but she was speaking to the obstetrician in front of the woman, saying, I don't agree with what you're doing, I'm not going to be part of it, and she walked out. It was an artificial rupture of membranes. We also spent a lot of time speaking to staff, and these are some of the things that they told us. This is the really measured version. That's about as dispassionate as it gets, but boy, was that comment right. Oh, sorry, I've jumped twice there. There were some descriptions of the sort of behaviour that people saw and the way that they found people's attitudes. The first part, you probably won't be surprised to know, relates to obstetricians. The second part, you may also not be surprised to know, relates to midwives. That was a member of staff reporting their distress at being spoken to in a humiliating way in front of patients. And one of the recurring themes here is that all this gets played out in front of women and their families. That was an experienced obstetrician who was in there as part of an assessment team, and he'd seen plenty of obstetric and midwifery cultures around the country. I shouldn't leave out paediatrics here, by the way. They're slightly less prominent, but there were some equally difficult problems with attitude and behaviour amongst paediatricians. Somebody else reporting on how they felt going to work and how they were made to feel. That was the answer to a question on a trust questionnaire. And the question was, what constitutes a good day for you? And that was a member of staff's response. Not a happy place to work, I think you'd be safe to say. When the trust was subject to challenge externally, whether it was from the Clinical Commissioning Group or from the Care Quality Commission, or later when it was from HCIB, they were met with anger and defensiveness. And the trust staff were quite open about that. They said there was a conscious decision that they would, at every opportunity, fight the regulators. Another regulator, no, sorry, my mistake, a CCG, a member of staff at the CCG, who really didn't like talking to people in the trust because of the reaction that she got. That was a senior obstetrician responding to the RCOG report that was done in 2015-2016. And that RCOG report actually highlighted quite a number of the issues that we've done in 2022. But that was their response to it. It was hearsay and uncorroborated comments, a load of rubbish. That's a trainee obstetrician reporting being left to manage situations that he didn't feel capable of dealing with. If phoned at night, they wouldn't come in. And that was so well known in that particular hospital, that's Margate as it happens, that people stopped phoning them. They worked around the problem. But that meant that many, many trainees at staff grade, doctors and locums were operating outside of their competence, and there were some dire results as a consequence of that. The same sort of communications, attitudes, behaviours were also found in the aftermath when things had gone very badly wrong, typically stillbirths, neonatal deaths and other serious problems. You might think that's somebody trying to comfort a patient, but actually that was following a failed resuscitation where the senior paediatrician had not been called in time. Sorry, there's a bit of a delay on that. That was a midwife who'd failed to spot an imperforate anus on a newborn baby. Led to a serious emergency overnight, and the baby almost died before they were effectively treated. And she came back, and that's what she said. You do remember I was handing over. She didn't ask how the baby was. She said, you do remember I was handing over. That's why I missed the imperforate anus. I have to look at that one twice. Because the first time you look at it, you think, well, that's one member of staff to another. No, it isn't. That's one member of staff to a woman who's just lost her baby. Is there anything you think you could have done better? Clear blame culture. Find the most junior member of staff who you might be able to say had messed up, pin it all on them and discipline them or whatever you can, instead of looking and learning when something had gone wrong. Some of you may recognise that one as well. That's a very common phenomenon, I think. Doctors were treated very differently to midwives in the aftermath of serious problems. I'm not saying that disciplining midwives is right either, by the way. Sorry, have I skipped twice again? Yeah, that's a member of staff. They knew that it was wrong to actively go out of your way to avoid learning because you'll do it again. And the corresponding take from a family who had been affected by this. So what they couldn't live with was the falsifying and the blame because they never knew the truth. Well, we helped them to find a bit of it, I hope. This was the Care Quality Commission. They rated the trust inadequate back in 2015. And the Trust's reaction was to spend 6 months arguing about the punctuation and the typos in the report. And they refused to accept that there was anything in the report until they'd corrected the commas. That could be anybody. I mean, we just heard that so many times from families, from other members of staff. There was clearly what I think you'd be safe to call a toxic culture there. And that was from HSIB, senior member of staff, who worryingly says not only why don't behaviours change, but also they see the same themes coming up in other trusts across the country, which is one of the reasons, not the only reason, but one of the reasons why we have been at pains to say it would be wrong to assume that these things are restricted to East Kent. It isn't just a one-off. Okay. People sometimes accuse me of getting a bit passionate about that stuff, and I hope that I've given you a bit of a flavour of why I do from that. We listened to 202 families, and just about every one of them told us stories that were something like that. So switching that off and going on to the let's be objective and dispassionate mode, I hope, I try to draw out some underlying themes in the report. Nope. Sorry, not quite sure what's gone wrong there.
I'll sort it out up at this end.
Thanks. Okay, let me try and advance it. That's better. Yes, thank you. That's great. Okay, the first one was very, very obvious was failures of team working. Lack of trust and respect. I think that should come through from what I said before. Dominant egos, informal hierarchies that extended absolutely to bullying and intimidation. People were sometimes challenged if inexperienced, if they were not a member of the midwifery A team or they were a member of junior obstetric staff, they were challenged to achieve a normal delivery. Don't come back and bother us with problems about complications. You get on and deliver the baby. I don't have to tell you, I'm sure, how downright dangerous that is. We were also very struck by repeated accounts of people having a different purpose. They thought they were there to achieve something different. In particular, the midwives thought that they were there to achieve minimal intervention, no intervention, resist recommendations of intervention by obstetricians. And our conclusion was, these conflicts were played out publicly, our conclusion was you can't have a group with different objectives and call them a team. They're not a team. They're trying to achieve different things. Secondly, failures of professionalism. Women treated appallingly by midwives and by obstetricians. Colleagues treated equally badly by their colleagues within the same professional group and across professional groups. Clear evidence of people trying to shift blame onto their colleagues when something had gone wrong, and trying to shift blame onto women for bad outcomes. And again, played out publicly for families. That was a paediatrician being challenged about what had gone wrong with a baby who died. And he told them to go and ask the obstetricians. Thirdly, failures of compassion and listening. I mean, I hope I've given you sufficient examples of uncompassionate care there that I don't need to labour the point too much. But we heard that from just about every one of the 202 people that we spoke to. Dismissive and uncaring attitudes, not listening. People told them that they were in labour and they were sent away and came back with serious problems because they were in active labour at the time, excuse me. People reported reduced fetal movements and were not told to come and be assessed. They were sent away again. People told them that they had ruptured their membranes, and they were told no, that it was urinary incontinence and they should go away, and came back with babies with chorioamnionitis. It's not only uncaring, it's bad practice too. It led directly to those sorts of poor outcomes. As bad, I think, it led to a permanent legacy amongst the people we spoke to. Some of them were still reliving it, you know, when we spoke to them. I talked to somebody yesterday who said she looks at the notes of the events leading up to her baby's death every week. She can't help herself. And that, the chap down in the bottom right there, just in case you were wondering, is William Osler, who said, around about 1900, listen to the patient, they're telling you the diagnosis. And I think that's as true in 2022. It's a favourite one of mine. Same sorts of failures after safety incidents. Similar attitudes, lack of compassion, shifting blame, defensiveness, clearly a culture of fear when something had gone wrong in the unit. Sorry, this thing sometimes works and sometimes it doesn't. At trust board level as well as at clinician level, denial, deflection and dishonesty. There isn't a problem here, there's nothing to see. All of which means I don't have to tell you failure to learn. So they kept on doing the same things over and over. And Florence Nightingale said how very little can be done under the spirit of fear, which is clearly a part of what was going on there. What did that lead to in East Kent? We had 202 families to talk to who came forward. Each of them had a case assessment. We looked for suboptimal care. We used the confidential inquiry into stillbirths and deaths in infancy classification, a CESD classification, which links it to what you would expect the outcome to be if the care had been given to the appropriate standard. And 97 could have had a different outcome, CESD level 2 or level 3. So half of the people we spoke to, round about. 45 of the 65 baby deaths, level 2 or level 3, suboptimal care. These are underestimates, these numbers, because we didn't go out and, unlike other investigations, we didn't go out and seek patients. We relied on people who wanted to come and talk to us. And a part of the reason for that is after we'd spoken to 202 families, we were pretty convinced that we knew enough to be able to write a report which was fair and true. So we didn't look for any more. So I think there would be more cases if anybody tried. As well as all of that, just about everybody we spoke to was still carrying the scars of what had happened and how they'd been spoken to and how they'd been dealt with and what had happened in the aftermath of things going wrong. Very worryingly, from our perspective, we couldn't find any improvement over the whole period. Things were still happening in 2020, actually after 2020, but we had to disregard them because that's when our terms of reference ended, that were very, very similar to the things that earlier on in the period. And over that period, there was a whole series of missed opportunities by the trust itself, by the board and the management. We counted 8. You could classify them as being others. They ranged from internal investigations. Medical director says there might be a problem and wants to review the unit. External reviews, complaints of bullying and harassment by members of staff. CQC inspections, RCOG report, HSIB, the death and inquest into the death of Harry Richford. All of these were opportunities for the trust to say, hang on, we've got a problem here, we need to know more about it, we need to find out what's going on. And in every single case they didn't. They found a reason to say, there's nothing to see here. They wrote an action plan. In fact, one of the staff we interviewed told us if there's one thing that East Kent can do, it's write an action plan. But nothing ever changed as a result of the action plans they wrote. They told people who challenged them externally that they were the best trust in the country on the basis that in 2009, I think, they had won a Dr. Foster Trust of the Year award. And they lived on that for the next 13 years. They treated challenge with hostility and aggression. The Why Are You Here, that was the HSIB team who were so worried that they were seeing so many cases from the trust that they asked for a meeting with the chief exec and medical director and nursing director. And they were kept waiting in a corridor for 20 minutes. And then when they walked in, they said, why are you here? What are you doing here? We don't understand. And all of that led to the conclusion at board level that if all was not well, at least it was good enough for East Kent. We heard good enough for East Kent a number of times. Failing to read signals, whatever the setting, risks disaster. So, very briefly, what we didn't do was make traditional recommendations. And there's a reason for that. Since 2015, we've had better births, we've had safer maternity care, we've had Each Baby Counts, we've had Saving Babies' Lives. The maternity services are awash with recommendations and initiatives. We thought the last thing they needed was some more. And in any case, what would we do? We'd either just say the same as other people had said previously, or we'd say something different, which would be worse. I don't know. Because over that time, we've had Morecambe Bay, which arguably started a lot of that. We've had Shrewsbury and Telford. We've had problems in Wales and elsewhere. We've had East Kent, and we've had Nottingham. And I believe there are others out there that haven't reached the same level of prominence yet. So whatever we're doing, it's not working. So firstly, we did not want to make traditional recommendations. We wanted to look at this differently and try and look at some underlying themes. My nightmare is that there'll be another one of these in another couple of years. It won't be me doing it. I'm blooming sure they won't ask me to do it, but some poor soul is going to be asked to look at another one of these because somewhere else has come off the rails. And what do? We treat each one as if it's an isolated one-off that must never happen again. We heard lots of evidence that this is not restricted to East Kent. I don't think detailed operational recommendations are the way to go here, for all sorts of reasons. Not least, it's probably not very good practice to make them on the back of catastrophic failure, and it's probably not best to get a panel like that to make them either. So instead, what we've done is to identify 4 broad areas, and they're difficult. They're not simple things to address because they're about people's attitudes and behaviour in large measure. But in our view, it is very important that these are, in fact, addressed. And the first one is a signalling system. CQC is just rotten at picking up places that are going to come off the rails. They're not adapted for it. They would, on a good day, I think, say that wasn't their purpose. And I think that's right. We don't look at outcomes. We collect loads of data in maternity services, but we don't look at outcomes. There are no outcome measures. When we do get it, we analyse it poorly. We tend to rank it. We put it into compressed distributions and look at somebody who's 5% over the mean. Most trusts would look at being 5% over the mean and say, well, that's not so bad, is it? And there's plenty of others in the same position, so nothing happens. We need proper outcome indicators. They're clinically relevant. You can adjust them for risk. They're based on available data. You can produce them regularly so that, oh yes, and you need to take account of natural variation. Some of you might recognise I'm talking about statistical process control here, which for some reason is a huge red flag in maternity services, and it has to stop being a huge red flag in maternity services because you need to account for the natural variation. And this information needs to be there for women, for clinicians who should want to look at this and know where they stand and how they can be better, excuse me, and for trusts and for regulators. Finding signals amongst the noise. You can't really see the picture there, but it's a funnel plot of different reporting rates, actually. It's not a very good indicator for all sorts of reasons, but it shows the amount of natural variation there is before you squeeze all the life out of it, and how you can account for some of that. Second really difficult area, standards of behaviour. I know I need to speed up a bit. I get that maternity staff are under strain. We did not find that under-resourcing and understaffing was the cause of problems in East Kent. It wasn't. Even if it had been, I do not believe that it's any excuse for the aggression, the hostility, the rudeness that we heard about over and over again. I know people don't learn this stuff in the classroom, and I'm sure they're not selected for being like that, but they learn it from role models in some places like East Kent, because it's normalised. That's how we behave here. And so if you want to fit in here, that's what you do too. There is a particular problem about intransigent consultants. I'm sure Liam knows way more about this than I do, but you get some consultants with very, very bad behaviour. It's very difficult to do anything. I could expand on that later, but I'll just leave it there for the minute. Effective clinical leadership is crucial. The rider I would add to that is people have to want to be led as well, or at least accept being led. And certainly the intransigent consultants don't. They don't think that a clinical director or a medical director has any jurisdiction. Technical care is not enough. Okay, speeding up a little bit more. Flawed team working, I'm sure that's come across. Both within and across professional groups. Terrible behaviour. Trainees unsupported. Lack of common purpose. It does worry me that a significant number of midwives from somewhere or other get the idea that their job is to protect the woman from the obstetricians. I just think that's so toxic. I mean, how are you supposed to have a proper team that trusts each other if half of them think they're there to protect the patient from the other people? It has to change. Leadership and training, yeah, okay. What we've said is we don't know the answer to any of these things, by the way. We need people with bigger brains than ours who can get to work on this and tell us what the answers might be. But for goodness sake, stop just putting it in the too difficult box. Right, last one, organisational behaviour. That is a shot of the pitch at Hillsborough in 1989, because like very many other organisations, the South Yorkshire Police responded with those. They responded with denial, deflection, dishonesty and aggression, but so do many trusts, if challenged. They do this because they're protecting their reputation. I think reputation is one of the most misused, reputation management is one of the most misused phrases around at the minute. I get that you have to do it, but as an excuse for concealing the truth for people, it doesn't wash with me. Current disincentives to do that are ineffective. Certainly the duty of candour is not effective in places like East Kent. Maybe it works in some places, but it was a tick box exercise in East Kent. They sent the most junior member of staff to have a little conversation and then ticked a box that said duty of candour done. And then carried on denying everything. I do have a concern about the revolving door for CEOs and chairs. They had an enormous number of CEOs and chairs in rapid succession in East Kent. The one that actually looked as if he was making a difference in maternity services was a victim of that as well, because he couldn't sort out the accident and emergency department. The rapid turnover doesn't help, and it's a product of the heroic management theory, I think, that you can send in a new person at the top and they'll just sort out all the problems. It didn't work. I have also made the nearest thing to a specific recommendation, I think, which is that I wish that the Public Authority Accountability Bill would be resurrected in Parliament. That would place a statutory duty on public bodies not to conceal the truth, to tell people the truth, and not just as a one-off, as a duty of candour, which doesn't work. And I think it's beyond time it was done. Loads and loads of people helped us on this, staff and families, gave of their time, and often at great cost to themselves. I think we owe it to them to learn and improve for women using maternity care, not just in East Kent. And if I could leave you with one final thought, it would be something that I first heard from the chair at the top of the table there a long time ago, which was, please don't say it could never happen here. It's the worst possible thing you can say. I'm sure you've heard it too. Thank you. Very happy to take any questions. Apologies if I've overrun a bit.
No, you've been absolutely to time, Bill, so thank you very much, and a hugely harrowing story, and we might ask you sometime about, probably shouldn't publicly, how you feel having been through an experience like that, because it must have been very traumatic for you listening to all of that, but you obviously, it's widely acknowledged, and not just me saying it, what a brilliant job you've done on it. So thank you for sharing it with us. I'll open it up now to questions and comments. We've got a reasonable amount of time, and because Bill won't know everybody, if you could just say who you are before you ask your question. Hannah.
Failed the first test. Hi, I'm Hannah Bowes. I'm one of the non-executive directors. Thank you very much for that. I found that very difficult to listen to be honest, but it's obviously really important that we all do. I wanted to ask how you, what response you've had to this so far, and how you feel this report has landed across the different desks that it needs to land on. Thank you.
Yeah, thank you. Disappointing. I mean, on the day that we disclosed the report to the families in Folkestone, because they had to hear it first before anybody else, and then later on it was reported in Parliament, the anger in the room from families, because they'd never had an action group, they never got together themselves before then. It was the first time a lot of them had seen each other. And the anger was absolutely palpable. And the sadness of it was that, although I tried very hard to transmit that in a kind of constructive way, by the time we got to 5 o'clock that night, and I walked into the studios at Millbank, having done a load of interviews down in Kent, the ticker tape on the bottom of the television screens at Millbank was reporting Suella Braverman's resignation, followed very rapidly by Liz Truss's resignation. We'd had a date previously, which got scuppered by, sadly, the Queen died. So we haven't had the best of luck with being able to make the right sort of impact with this. And there is a real danger there that people will find a way to take their eyes off the ball, because it's all a bit history now. It's too long ago. I've had some very constructive conversations with NHS England, who I think are quite keen to produce a kind of combined response to this and to Shrewsbury and Telford. I don't know whether they're going to wait for Nottingham, but haven't seen anything tangible come out of that yet. It's taken me until this Thursday coming to get into the Health Minister's diary, Maria Caulfield. So I'm speaking to her on Thursday morning, and I'm very much hoping that she's going to tell me that there's going to be a formal response from the government, because there hasn't been one yet. And I think linking that back to the anger that I heard on the day of the disclosure, you know, there's going to be problems if there is nothing forthcoming from the government. I should also perhaps say that I've spent the last 2 months talking to individual families about what happened in their particular case, and giving them an individual disclosure session. And just about everyone has said, well, you know, come on, this is all very well, but tell us what's going to happen.
Thank you, Bill. Rajesh.
Rajesh Nadkarni. I'm one of the Foundation Trust members on the board. So I'm just like Liam, thank you for sharing. I can't even imagine listening to 220 or 202 families. Just your reflection on one of the things you talked about, culture, and you described a lot of things about the toxicity and so on. Within kind of the mental health sector, and also within the care sector, there is this understanding of a closed culture where, you know, some deliberate self-harm happens to patients because they are dehumanized, and there's quite a lot of work which happens around that. Just a reflection with your last statement, which said, which you were very clear that you move away from that, you know, idea that it couldn't happen here. Do you think there's a lot of work to be done within the acute sector on this particular area?
I suspect so. I think that we heard obliquely and studiously ignored because it's outside the terms of reference, and I didn't want the report to be discredited because we'd strayed outside the terms of reference, that this was not restricted to maternity services, that there were echoes of it in other services too. I can't say for sure, but I would be surprised if it was purely a maternity problem. I mean, clearly there is a particular maternity element to it in that you have this issue of the different professions of midwifery and obstetrics needing to work together in a particular way or not, as the case may be. But then again, other acute specialties, they're increasingly dependent on multidisciplinary work, as you know, so I wouldn't be at all surprised, is all I can say.
Sam.
Thank you very much. Thank you very much for that, Bill. Just to echo colleagues, that was incredibly insightful and very moving, particularly listening to those sort of personal testimonies of people's experiences. I was struck by the quote, failing to read the signals risks the disaster. And I was also thinking about the role of leaders at all levels and how we can educate and support leaders around the various case studies, the examples, in terms of what those signals are. And I was particularly drawn to the point around defensiveness and people perhaps putting their reputation before seeking learning, insight and safety. And I was just curious about, with your vast experience, even beyond East Kent, what do you understand, or do you have a view on what drives those behaviours? Because I think we almost need to understand that to think about actually what we can do to mitigate the risk of it.
I think there's a reasonable amount of work and some experience as well that says that at individual level, people do it because of fear of being othered. You know, you're the person who couldn't manage the service in East Kent, or you're the person who couldn't manage whatever it was somewhere else. I think at organisational level, I guess that, but I don't know, I'm not an expert in this at all, that you get a kind of collective thinking, which starts out with several people thinking that, you know, that my reputation's a bit on the line here and I can't afford for it to be thought that I'd failed at this. I mean, I think that affects clinicians as well, you know. I can remember feeling like that if something didn't work like it was supposed to work. I can remember feeling really scared that I'd messed up and that would, you know, be held against me. And it certainly would have been by lots of people I worked for. And I think when you get round a table and you say, how are we going to handle this? It's probably self-reinforcing behaviour where you think, well, you know, we don't really want to go massively public on this and say how badly we've messed up. So how are we going to manage it? Well, the first thing you do is you put your hands around your homework. We tell people as little as possible. I remember Liam was talking about the old trust division in the introduction, and I remember one of our warning signs when I was looking at 57 trusts in Northern and Yorkshire was the ones that wouldn't share information with you. They were always the most worrying ones. And I think it progresses on from where you've started out, that you'll just not share stuff with people. You'll keep that report You know, it doesn't really have to be published. It doesn't have to be sent to other people in the unit, in the trust. And then it goes on to, well, we've never had that report. And, you know, you start to get the element of falsifying the information creeps in at that point. I've sometimes described it as being like a slippery slope, where you start out and it all seems sort of reasonable. And then you're halfway down the slope and you realise that you're in it too far to stop, and you've just got to keep going. And then you hit the bottom of the slope and some person like me turns up and does an investigation. You know, you stop at the top of the slope, not halfway down.
Neil.
Yes, hi, I'm Neil O'Brien, Executive Medical Director. I think my question relates to our responsiveness in detecting some of these issues in a timely way. We can certainly look at outcome data and never events, but then that almost, I think there'll be quite a delay in the potential for harm for the time that it takes for the system to pick those things up and then initiate any kind of formal investigation or intervention. I was just wondering if you've heard of any examples of where systems have got this absolutely right, where they have a much more refined way of picking up issues early and being able to respond instead of looking at things like outcome data, things like that. I've just wondered if you'd had any experience or insight into that.
Thanks. Yeah, one of the problems that I've had is that I've seen an incredibly biased sample over the last 12 years. So I can't really extrapolate to places that do it right. Having said that, one of the things that really worries me about the CQC assessments is there are 2 outstanding units in the country for maternity. I mean, blimey, 2 in the country. It's a bit of a sad indictment. Yes, I sort of agree with what you're saying about outcome data. It would be better to head it off before you got bad outcomes happening, of course. On the other hand, I think that we have to get away from the idea that you have to look at a year's worth of data at a time and it's probably 2 years in arrears. I want this to be real time. I'm trying to put together a task force with the right kind of people on, with the right kind of pedigree to do these things, and it will be real time data. Firstly, for the clinicians and the women using the unit, you know, so you can see where you might just be beginning to head up towards the action line instead of waiting until things have gone catastrophically wrong. So I'm a bit more optimistic about the outcome data. I agree that we're miles away from it at the minute. What it will be great to do is to know that everybody is on top of what they're doing and picking up any tendency that things were beginning to drift before it ever got to the problem of really bad outcomes. I don't know, but that's probably my biased sample. What strikes me very much as the first problem that I would like to sort out is that I don't know of a single one of these investigations that has ever been prompted by anything other than a group of very angry families saying things have gone wrong here and we've been lied to. Not one. I think we've got to get away from that first.
David Perdue.
Thank you. Hi, Bill. I'm David Perdue. I'm the Executive Chief Nurse in the ICB. I'm the SRO for the LMNS. And quite timely, we had a kind of discussion yesterday in terms of alliance, in terms of how we're working with all the different strands of networks, the ODN for neonates. And I suppose it was around, we had that discussion yesterday in terms of the signals and what we're looking at in an ICB for our 8 maternity units. And kind of how we use effective data, feedback from families to triangulate what's actually happening. Because actually all of us said if we could rank the trusts, we'd rank them, but that doesn't match anywhere near the information that we see from the hospitals. And I suppose the other bit is kind of when we're looking at that programme of where we are waiting for the single maternity plan, which is due kind of end of March. And the question that kind of you asked first of all is kind of your input into that and kind of how we need to structure some of our work streams going forward.
Yeah, thanks. I haven't had any input into the single national maternity plan. I've been invited to a couple of meetings, but I've been too busy doing the family sessions. So, you know, waiting with bated breath. I don't know yet. I agree entirely about the need to triangulate information. And I noticed that you mentioned complaints there, and boy, do we underrate complaints. I don't know whether anybody knows a lady called Susanna Stanford, who lives in Jesmond. She didn't, but she had a very bad experience with a failed regional anaesthesia, and wrote a lot about it, and has worked with a college of anaesthetists and all sorts of people and published stuff on it. And in one of the papers that she wrote recently, she said something that I thought was absolutely spot on the money, which is, if a clinician reports something not going right, it's called an incident. If a patient reports something not going right, it's called a complaint. It stigmatizes them right from the outset. They're a troublemaker. We have to get away from that, you know, because I do think we undervalue complaints.
You, Bill. Jacqueline. Got a lot to get through, which is good because it's generated a huge amount of interest, but we'll just keep an eye on the time. Jacqueline.
Hello, Bill. I'm Jacqueline Myers, and I'm the Chief of Strategy and Operations. I wanted to ask you, thinking about us as an integrated care board, and I know you wanted to sort of steer clear of making specific, if you like, remedies, but if you could suggest a couple of things that we might focus on to address the very broad themes of your 4 recommendations in the work that we do with the wider system, what might you choose?
Yeah, I've got a kind of self-denying ordinance at work here, I'm afraid. So you're asking me to reach it. I don't want to make specific operational recommendations. When I did the Morecambe Bay investigation, I think there were 44. It's too many. All I can say in my defence is that Robert Francis had 200 and something, so I did better than him, but it's too many. And I don't think it's appropriate for anybody. I mean, I had a great panel working on East Kent, but I don't think any of them would want to come in here and say, we could suggest to you how you could do things differently. I don't think it's right. I think we can say, these are the areas that we really want you to have in mind. But after that, I want to bring my self-denying ordinance into play, I'm afraid.
Ken.
Hi, Bill. What reaction have you had from the professional bodies, particularly obstetricians and midwives, to some of this? And what implications are there for the way we train our doctors and midwives of the future, particularly the more behavioural aspects of some of this stuff?
Yeah, that's a great question. Thanks again. Guarded, I think, would be the kindest way to describe the response, and disappointed. And the thing that the professional bodies are disappointed with is, but you haven't said we need loads more staff. And I've said, look, if I'd found that that was the cause of these problems, then I would have said so, but I didn't. And by the way, I have said, I'm not disagreeing with anything that Donna Ruckenden has said in relation to Shrewsbury and Telford, so there's your hook to hang that one on. I'm not disagreeing with it. But I'm not going to say that these things caused problems when they didn't. I've had quite a strident response from the radical wing of the midwifery profession because of the stuff about normal delivery and no C-sections and vaginal birth after section. And I don't think there's any future in having people who are there to protect a group of patients against a group of staff. So that they have responded pretty strongly. But another self-denying ordinance is I don't do anything on social media, so that's largely just gone straight over my head.
Graham.
Thank you, Chairman. Hi, Bill. Graham Evans, I'm the Executive Chief Digital and Information Officer, so the commentary around data and signals from noise is very relevant. I think what I'm about to ask has probably been already asked from a number of colleagues, but it's understanding those warning signs as a system. And whilst maternity may be the case in point here, there are lots of other clinical services that the same things could be, be behind the scenes, so to speak. speaking to the staff, speaking to the patients, I think the signals were there. You know, it was hidden in plain sight almost. You know, given that there was a high turnover of chief executives, perhaps an under-reporting culture, I think fundamentally this is about culture. What we want to do as a health and care system is try to identify those warning signs early. And we don't have answers yet, but any learning that we can glean from any of these things can be put to good effect in our future strategy. So it's really just a comment, Bill, that really welcome your very open and honest feedback. Thank you.
Thank you.
Mike.
Hi, Bill, thank you for that. So I'm a GP, and the quote about listen to the patient, they're telling you the diagnosis, I repeat to myself as a mantra on a regular basis to stop myself interrupting patients and listen. And on that point, are we listening, in East Kent, were they listening enough to the content of the complaints? Were they dismissing the complaints? How can we learn from that? Obviously, we can look at the volume of complaints, and that gives us an early signal if there's a problem. But sometimes there's natural variation, as you've highlighted, and complaints don't necessarily correlate with practice in all cases, albeit one would assume if there's a lot, there is a problem. How do we, as a system, listen to the content of those complaints so we're listening to the patients?
Yeah, thank you. Nice to meet another Osler fan. I was dismayed a number of years ago to find that the average time until a doctor interrupts a patient is 40 seconds. Shocking. Anyway, yeah, complaints like incident investigations were treated defensively and dismissively. The number of times when they actually did a decent incident investigation, out of the ones that we looked at, I could count on the fingers of one hand. And I wonder about why they were the exceptions. The great majority, they were clearly exercises in finding defensively why nothing had really gone wrong, and if it had, it was just bad luck. They were not vehicles for looking at what might be done differently and how the outcome might have been might have turned out differently if you had. And I think that's really the root of the problem. I mean, counting them would have been one thing, but then what do you benchmark it against? You know, we don't really do that systematically at the moment. I think we should.
Syra.
Thank you, Dr. Kirkwood. I'm Syra Malik, I'm one of the GPs as well. So thank you for that report. It was very difficult to read, but a very honest and open account, which was relatable. I had to read the report 4 times. I was kind of that mind-boggled by what I was reading. And I guess my points have already been covered by many of my colleagues, but I just wanted to share my observations that in the report, there seemed to be many areas where many organisations were involved at many different levels. And I guess, to my mind, my observation was who should have intervened and when was that red flag going up? In page 108, in which one of the staff said, well, that's what's that got to do with this from the safety element, from a safety perspective, because safety is everybody's business, you know, in healthcare. You know, is this something that we should be looking at closely in our quality and safety review meetings? And lastly, I'll just say, my colleagues have said, how will we as the ICB read the signals? I think that's a core learning point for us to take away from this very important report. Thank you.
Thank you, yeah. There were so many points at which intervention could have happened by the Trust Board, by the CCGs, by CQC, by the RCOG. I was disappointed with the RCOG response. I mean, they produced a very effective report, but then basically just sort of dumped it. They didn't say, well, you know, what can these are your members here who are doing this. You know, they didn't say, well, what help can we be? They tried to come back in 6 months and ask, how's it going? But the trust said, well, we're not interested in telling you, and that was that. So there were just so many. I mean, we delineated 8 separate instances, but you could probably have found 108 actually. And there was just a collective will, I think, to make it all go away, my view, because it's too difficult. They just felt unable to do anything to sort it out.
Annie.
just to thank you. I mean, a real privilege to listen to that today. I was really moved. A couple of questions from me, if I may, and comments. So there's something about the performance in real time, and I think we've got real-time examples in the Northeast on the back of similar concerns raised by women of statistically processed control charts, weekly measurement of the woman's experience of their acute maternity experience, triangulated with staff experience, complaints, clinical incidents, and also social media activity, and a good route from the public. But my question is, and I really welcome the fact that there aren't 44 recommendations when we're trying to change culture, and whenever a recommendation did change culture, but what are your reflections of if we flipped it as a system in the focus and endeavour for improvement, we held organisations to account not just for performance and performance through the eyes of women experiencing it, but for the learning. What would that look like from your perspective? And the second question from me was about just curiosity of having spoken to 202 families. I'm trying to imagine that process, having gone through that. What new learning did you walk away with? What's changed for you having gone through that process?
Gosh, thank you. Yeah, it's quite a bit, really. I think if I go back and read the papers relating to Morecambe Bay now, it was only 2015, but I actually cringe at some of the things that we did, just because that was the first of its kind. Certainly, as far as I was concerned, I think it was the first major maternity investigation. And I think that there has been an enormous amount of getting better at doing it in the way that you link with the families, in the way that you listen to the families, in the way that you make them able to raise their concerns, but then you're able to triangulate them with the staff. Because I know, there's a tendency to sort of downplay that element of it in some investigations, and I think that's very regrettable, because if you haven't given staff the chance to tell their side of the story, even if you don't necessarily agree with it, you're missing a lot of the richness of the information. My sadness is that every time we do one of these, and I know I've just said I wish we never have to do another one again, but every time we do, we have to reinvent it from scratch, because there is no repository of learning of these kind of things about how you do an effective investigation, economically and efficiently and kindly and listening to people. It costs a lot, not in financial terms. One of my proud boasts is that I'm one of the cheapest around, but maybe that's subject to misinterpretation, I don't know. But in personal terms, you have to put a hell of a lot into it. It's, talking to families running into 3 figures and giving all of that time to them, and you have to have mastered that case before you talk to them, because you don't know what they're going to ask you. So you have to have spent an hour, 2 hours going through all of the records and making sure that you're on top of everything. But if you try and cut corners on that, I think you're not going to end up with the same quality of experience for the people who've been involved in these things. Sorry, I've rambled on about the second part of your question. I've forgotten the first part now. Can you remind me?
It was around the learning, actually, if we were just in terms of organisations held to account for the learning that takes place, rather than a focus on performance when people can say we're just so far above the mean. We're doing all right.
Yeah, okay. Everything I've learned about safety and safety investigations, I've learned from Sir Liam at the top of the table there, so I'm not going to have anything meaningful to contribute on that one. You've got a world expert there, I couldn't possibly add to that.
Okay, thank you very much, Bill. David.
Thank you. David Thompson, I represent the North East North Cumbria Health Watch network. So trust boards and ICBs receive huge amount of detailed information, mainly on clinical aspects and so on. And hidden in the reports will be something about the family and friends test, staff surveys and so on. Do you think there should be a sea change in adding to that repertoire of invaluable information, much more focus on the views of service users to bring to the boards, and the responsibility on those who bring reports to the board to report on what the service users are saying? So it's high profile, it's much more immediate, and provides the key word, insight into what is happening, and therefore perhaps sort of bring to the fore concerns much earlier in the discussion?
Yes, absolutely. I think all of that. I think that at the very, very least, that would give a better avenue for people to raise their concerns before it had reached the pitch where you've got an action group formed because there are disasters and people are not finding out the truth. I think that would be wonderful. That would be a real example of early warning rather than waiting until the trains come off the track because the signals were ignored. There is a particular sort of technical issue in maternity services which makes them a little different, and that is that my colleague on the Morecambe Bay panel, Jimmy Walker, used to say, 96% of women could give birth under a gooseberry bush without an attendant there, and it would be fine. And so it's the 4% where these things are going wrong in. The problem with that is if you're doing something like the family and friends test or the patient experience test, it's going to be measured on a different scale because everything went fine for them, and so they're looking for different things. You need to find a way to weight what happened to the 4% that had absolutely disastrous outcomes so that they're not outweighed by all the good stuff coming from the 96.
Thank you.
Neil.
Thanks. I just want to check that I'm not making an assumption about some of the conclusions that were drawn. Thinking about the cases that could have had a different outcome, did you find that there was no deficiencies in skills, knowledge, resources, facilities, implementation of guidelines within those cases? Was that knowledge and resource there? It just was very poorly applied because of the culture within the environment that people were working. Is that a fair summary of, or were there? Because we spend a lot of time thinking about, are guidelines implemented? Is there enough beds? Is there enough staff on? That kind of thing. I'm just interested in maybe some of that clarification, if that's okay.
Yeah, sure. We didn't find incidents where things had gone wrong because there wasn't, no, that's not right. We did find incidents where things had gone wrong because a member of staff wasn't available, but it was because they'd chosen to make themselves unavailable. It was because they'd left the locum, who was untried and untested, in charge of a labour ward that he or she was not equipped to deal with. We were very careful to look for problems of staffing and resourcing, and indeed many of the 100 and something staff who spoke to us clearly came with a pre-prepared agenda to tell us that it was all about short staffing. But it was impossible to document that on the basis of the records and the staffing levels and the reports that were going to the board and all the rest of it. There was no evidence of it. What there clearly was evidence of was people choosing not to support their colleagues and choosing to leave their colleagues to manage difficult situations that they weren't equipped to deal with through their own inexperience. And maybe they were trying to apply the right guidelines, but my heart would go out to a junior midwife who is not part of the A-team. They're not accepted in that unit. They're trying to be accepted in that unit. And on their first week in the labour ward, they're told the way to get accepted in this unit is, we'll put you with Mrs. Bloggs, who's got serious problems and is a high-risk patient in the end room. And if you can come out with a normal delivery, then you might be accepted. And that's the sort of level, I'm afraid, of the deficiencies that were there. They were deficiencies of attitude and behaviour more than they were technical knowledge.
Well, Bill, thank you for sharing your great wisdom and experience with us today. In my view, the NHS as a whole owes you a great, huge debt of gratitude for the commitment and the compassion you've shown to looking at these very serious problems that nobody else is really going near. And what we've learned from you today, and I'm sure what others will learn as you go around the country, as I know you have, I hope it will this time lead to some change that's going to remove these things from the list of systemic problems, which is probably the most worrying part of all NHS standards of care, things that are systemic and institutional. So thank you. You're kind enough to join us again with a wider group of people after lunch. If I could just ask you to sit tight for a minute and I'll close the meeting. Claire, have we any pre-notified questions from members of the public?
No, Chairman.
Okay, and we said at the beginning that you didn't have any other business, so I can now declare the meeting closed. Thank you.